So we are live.
A very good evening. On behalf of the Scientific Committee of the AIOS, I welcome you all to this global webinar on cataract case files. In this COVID era, webinars have become a new normal, both for learning and teaching. The concept of video case-based files is basically aimed at giving a take-home pearl to the audience. As we cruise through this webinar, we will have two keynote addresses and a 4-minute video presentation followed by a 6-minute discussion by the discussants who are stalwarts in the field of cataract in India and across the globe. My special thanks to Steve, Professor Chi, and Sergio for sparing time and joining us for this global webinar. Apart from all the stalwarts, the panelists, and the presenters, thank you once again. I'll request the Chairman Scientific Committee AIOS, Dr. Partha Biswas, to take on the stage from now. Thank you, sir.
Thank you, Sonu. AIOS Scientific Committee presents the cataract case files, and it's a global webinar, as Sonu just said. It's 28th of June today and 6 p.m. So welcome to the webinar. And of course, we have the webinar a sponsor by Centis. Sunilji, can you play the video, please? Mr. Sunil? Shall I start sharing my slide once again? Let me introduce you to my team of scientific committee at AIOS, Dr. Amit Porwal, Dr. Fairuz, Dr. J.S. Balla, Dr. K.P. Kudlu, Dr. Parikshit Gogte, Dr. Sonu Goel, and Dr. Somshila Murthy. This big team is responsible for the big things that we do at Scientific Committee. Let me also welcome our President AIOS, Dr. Mahipal Sachdev, and he's on the expert panel. He's Chairman, Scientific Committee, IRSI, Chairman and Managing Director for Center for Sight, Group of Eye Hospitals. Let me also welcome Dr. Devashish Bhattacharya, Founder Chairman of Disha Eye Hospitals and past President AIOS. The expert panel also has Dr. D. Ramamurthy, Founder Chairman of the Eye Foundation and past President AIOS as well. We have Dr. Northeesh Shroff, Medical Director and partner, Shroff Eye Center. We also have Dr. Suhas Haldipurkar, founder of Lakshmi Eye Hospital, Lakshmi Eye Institute, and Lakshmi Charitable Trust. Welcome, sir. We have with us Professor Jeevan Singh Titial, Professor and Head, Cornea, Cataract and Refractive Surgery Services, Dr. R.P. Center of Ophthalmic Sciences, AIMS, New Delhi. We have on our expert panel, Dr. S.P.S. Grewal, Founder and Managing Director of Grewal Eye Institute, Chandigarh. Welcome, sir. We have with us Dr. Haripriya Arvind, Head of Cataract and IOL Services at Aravind Eye Hospital, Madurai. Currently, she's in charge of the Cataract Clinic at Aravind Eye Hospital, Chennai. We have with us Professor Namrata Sharma, Secretary AIOS, Professor of Ophthalmology, Cataract, Cornea and Refractive Services, RP Center, AIMS, New Delhi. We have with us Dr. J.K. Reddy, Director, Shankara Eye Care, Coimbatore. And we have our two moderators, Dr. Krishna Prasad Kudlu and Dr. Sonu Goel, the anchors of this program, who have worked very, very hard to bring this program to its culmination now. And this is what we would give to them. Thank you, Sonu. Thank you, Krishna Prasad, for doing such a great job. Over to you. And I would like to invite now Dr. Namrata Sharma to give a welcome note to all our viewers, as well as to our panelists and speakers. Dr. Namrata, please.
Thank you, Partha. Thank you for this excellent webinar that we are doing, and congratulations to the AIOS Scientific Committee for starting this case files on cases and videos. I'm sure it is going to be a great webinar. I would especially like to welcome our international guests, Professor Chi, who's found time despite being so busy in WOC, and Dr. Steve Ashenoff from Canada, are very good friends, and of course, Dr. Sergio. At the same time, I would also like to welcome all our esteemed national faculty, seniors, peers, and juniors as well. And I'm sure it is going to be a great discussion. So welcome everyone.
Professor Dr. Mahipal Singh Sachdev, sir, to give the inaugural note and to inaugurate the program, sir.
So you have to unmute.
Thank you very much, Dr. Partha. I think as we all know, we have a dynamic chairman of the scientific committee, Dr. Partha, and I think all the 7 members of the scientific committee are par excellence, and they are actually dynamos, I would say, in themselves. And these case files that they have been organizing for the last couple of weeks, I think they have been greatly appreciated, and they are taking us to a level where we can take pearls from each videos that are there in different subspecialties. Just to share a secret to you, Sonu, we were together with Professor Sufak at the WOC, and she said that when she gets your call, she gets very, very nervous because you will call her again for a webinar, and she wants to be excused to be part in any more webinars done by you, Sonu. So I don't know how many times you have invited her, but Professor Su, I think it is really, really great to have you, because I am a great, and all of us in India are great admirers of your surgical skills. And I have had the opportunity to do live surgery along with you, and I know the skill, the expertise, and the calmness that you get into most difficult cases. So I would side with Sonu, and I'll keep on requesting you on behalf of various wings of AIOS to continue to give pearls to our ophthalmologist. Steve, we have all known him. He's a great person. The amount of work that he has done on viscoelastics is nobody's business. And welcome again, Dr. Shri Varshinov, for joining this. And also Sergio, I think he is a great surgeon, and thank you very much for joining in. So I think the scientific committee has put up a great show, and without much ado, I would wish to have them start this particular session. And all the very best for a lively, wonderful webinar. Over to you, Partha. Thank you.
Thank you very much, sir. So we have our two wonderful moderators who are going to carry us through this program. So over to you, Sonu and Kudlu.
Thank you so much, Dr. Mahipal, sir, for those kind words. And I think that has reassured me that Chi is now more Indianized, and she'll be more frequently running through our webinars. So I take an affirmative note, Professor Chi and Steve again, and Sergio, from you all. Thank you so much. So So now I welcome Professor Steve Arshinoff. He is the Associate Professor in the Department of Ophthalmology and Vision Sciences, the University of Toronto, Canada. His areas of research interest include ophthalmic viscosurgical devices and related surgical techniques, phacoemulsification machine design, immediately sequential bilateral cataract surgery, endophthalmitis prophylaxis, and medical outreach programs. He is on the editorial board of the Journal of Cataract and Refractive Surgery, 300 peer-reviewed publications, and 38 medical textbook chapters, and more than 1,000 of the academic lectures globally. He is the designer and the medical director of the OMACNIB, the Ontario Medical Association Canadian National Institute for the Blind, the Mobile Medical Eye Care Unit, MECU. So welcome, Steve, and he'll be delivering his keynote address on immediately sequential bilateral cataract surgery. I also welcome here Dr. Mahipal Sachdev, President AIOS, and Dr. Partha Biswas, the Chairman Scientific Committee AIOS, to be on the panel for the keynote. All to you, Steve.
Thank you very much, Dr. Goel, and thank you very much for inviting me to take part in this excellent symposium. You can see my slide now, I hope. So I've been invited to speak about bilateral cataract surgery in a number of places now. It seems to be becoming the new normal after COVID. So I tried to change to give you a bit different talk, and hopefully you'll appreciate it. Of course, I have no conflicts. Doesn't matter which eye you do. If you do one or two, it's all the same thing, whoever you consult for. So due to COVID-19 restrictions, everybody suddenly wants to do bilateral cataract surgery. It almost doubles the number of cases you can do per day when you have to clean your operating room and ventilate it for a while. And so dollars and time have become big issues in ophthalmology, which I'd like to mention. I don't know about in India because many of you are in private practice, but in North America, it's a big difference. So I was the first to study cost and reimbursement of bilateral surgery because I was one of the first in the world to do it. And I was being exposed to prejudice and issues about why we do bilateral surgery. So we wrote a number of papers. And then my summary of this is that, it's appropriate to study comparative costing and reimbursement of doing bilateral surgery or unilateral surgery twice in different jurisdictions. I think it's not appropriate and perhaps unethical for us to choose to do unilateral or bilateral surgery because one pays us better than the other. But it is appropriate to lobby jurisdictions to fund surgery equally. So whether you choose to do bilateral or unilateral surgery based upon the specific case, you're funded fairly. So that's the brief summary of the finances. Now, so the next question comes up is, when should one consider embarking upon bilateral cataract surgery? Well, the summary briefly is when you have an extremely low complication rate. Once every step of your procedure has been perfected and you know how to dilate pupils intraoperatively as well as preoperatively, you can deal with small pupils. You understand OVDs, how to use different ones in different situations. You understand phaco machines and how you can set them better, perhaps in different situations. You're competent with IA, doing very well. Your biometry and your IOL selection implantation are all accurate, so you're not replacing lenses. You use intracameral antibiotics always, and you're good at it, and you make sure that you seal the incisions, and your surgery is more or less complication-free, and you have a routine of post-operative drops and follow-up that works very well. Unless you have all of those things worked out well for one eye, you probably shouldn't do two. So the next question is, well, if that's the case, why then do you perform bilateral surgery? And the answer simply is, for all of us who do it, it's better for the patient and it's better for everybody else who's concerned. So I think I was the first in the world to publish a relatively large case of 1,020 consecutive bilateral surgery patients completed in 2002. And we had an extremely low complication rate, and so we were quite happy to publish it. And then just after our publication, we found that, well, we weren't the only ones in the world. The Finns were probably first as a country because they were adopting completely elective by patient choice bilateral cataract surgery since about 2002. Sweden was looking at doing bilateral surgery in 2003, and Bjorn Johansson published a smaller series than mine, roughly the same time as ours. And in Spain, the group on the Canary Islands was approaching the government to try to submit a study to the government so they would approve bilateral surgery as being equally safe and effective as unilateral surgery. And it's the only country in the world where an act of parliament eventually reviewed the study and decided that bilateral surgery was equally safe and effective as unilateral surgery. So my background is that I've been doing routine bilateral surgery by patient election since 1996, probably the first in the world to do them electively. And I've done about 12,000 eyes by now, and 80% of my surgeries now are bilateral surgeries. One of the things I think is very important, I use intracameral antibiotics in every case. I initially used vancomycin that I learned from Gimbel and Gills, but we stopped using that in 2003 because the government told us we had to use a generic version, which was made in Toronto and was very cheap, but unfortunately it always caused TAS. So that ruled out vancomycin. So after looking around the world for a better drug, I decided that Vigamox was probably the best. And every case since then, I've been using Vigamox, and the best dose is, I've decided 600 micrograms in 0.4 cc, so you can wash out the anterior chamber. We've done about 10,000 cases like that, and we've had no side effects of the drug and no infections at this dose. So interestingly enough, I go around the world and talk about bilateral surgery, and I thought that people weren't getting interested. But then recently I was involved in a webinar from Quebec City, which was in French, and the chairman of the department there, Marie-Ève Legaret, got up and said that, well, after I spoke to them in 2015 or so, in 2016, they began doing bilateral cataract surgery, and they rapidly went from 6% to 22%, and now to almost 60% of their cases when the patients are given a choice. And like everyone else in the world, they found that their infection rate actually went down, and their complication rate went down. And they're now getting an infection rate of about 1 in 14,500, which is similar to what we showed with the International Society in reviewing 125,000 cases we did. But we weren't the first to do bilateral surgery. It turns out the first was Jacques Daviel, who in April the 8th, 1747, performed his first extracapsular surgery after finding out that couching didn't work very well. And he did the left eye first, which is what I do, but I don't do that because of him. It's just how our room is laid out. And by 1756, he'd done about 434 cases, and he deemed about 88.5% of these to be perfectly successful, which is extremely good considering the time. So we're all following in footsteps who've gone before us. We began our society, the International Society of Bilateral Cataract Surgeons, in 2008. Most of our members initially were from Spain. We had 2 from Britain, 1 Swede, 1 Canadian, and 1 South African, totaling 9. There are only 7 of us in the picture because 1 guy is taking the picture and 1 wasn't there. Our society has 1 rule, and the rule is that if you're doing bilateral surgery and you get an unresolved complication in the first eye, the second eye should be deferred. An unresolved complication is something like a broken capsule with a dropped nucleus. It doesn't mean that perhaps the capsular excess was errant, but you rescued it. That's not considered to be an unresolved complication. But we've also all discovered and believe firmly that the best time to operate on the second eye is just after gaining the experience of the first eye. And we think that's why we have such low complication rates and low infection rates, because the second eye of each patient is always much easier because it's pretty much exactly the same as the first eye, and you know exactly what issues you might run into. We suggest that everybody follow these principles of safe surgery for bilateral surgery. We published this in 2009 after arguing back and forth in our society for a year. And it's become pretty much a global standard for how to do bilateral cataract surgery safely. It's available on the ISBCS website or the Eye Foundation of Canada website, or if anybody asks me, I'll send it to you. So I began to get involved in debates, and I thought that people would be angry about bilateral surgery. And then the ASCRS and ESCRS both invited me in the same year to a big debate in front of the whole audience. And I was quite surprised because in both of them, the opposition evaporated immediately. I had been to Colorado and spoken in front of Kent Syverson's group. He was my opposition for the first one. And I found out that by the time he came to the meeting, they had converted about 70% to doing bilateral cataract surgery. And instead of him opposing me, he just agreed with the idea that it's much better. Jose Guel in Spain was not doing bilateral surgery, but when he went through all the literature and his colleagues that were doing it and looked it up carefully, he found out that the only reason not to do bilateral surgery is that he felt that patients may trivialize ophthalmology and surgery if it looks so easy, which is not a good reason not to do something. And then I met this group that invited me to New York because they have a center there and they were developing methods to do small incision cataract surgery in sub-Saharan Africa and parts of Asia, including some parts of India. And they wanted to do 1 million cataracts doing manual small incision cataract surgery with a kit they developed. And I went to New York and looked it over and talked to them. And they're a rather impressive group, but I really don't know how well they've done in their work since then. I do know that I've been asked to speak at the Manual Small Incision Society a couple of times with these webinars. And it's interesting, the excellent results that Indians particularly get with manual small incision cataract surgery. But I just thought I would suggest to you that the progression of cataract surgery really follows the same path in almost all countries. India, of course, was the first. Sushruta in about 500 BC was the first person or surgeon to do cataract surgery. And 2,000 years later, Jacques Daviel went to do extracapsular surgery instead of couching. And then 200 years later, we got IOLs when Ridley implanted them first with extracapsular cataract surgery. We then got a period of 25 years of intercapsular surgery, then back to extracaps and manual small incision surgery to implant lenses, and then 15 years later, phaco, and then 25 years later, femto. India is now on the bridge here between doing manual small incision surgery and phaco, with a few doing femto. But I suggest that as India's economy gets better, because India, I think, has an extremely good future economically, probably better than almost any country in the world. And I think he will progress the same way as the West has and move more and more to phaco and then to femto, which will become cheaper over time and perhaps we'll have new things. So I think you should be interested in the new things because that's where you're going to be headed. I'd like to talk about the advantages of doing bilateral surgery. And my favorite one is that we can do people we wouldn't otherwise do. So I began to do amblyopic eyes in about 2000 when some patients came in and they would have a narrow angle or some almost not that greatly significant reason to consider doing their amblyopic eye. And then I found out after doing 50 or 100 of these people that they see surprisingly well. And when you correct the optics of amblyopic eyes with an intraocular lens, a lot of them a year later see 20/40, 20/50 really quite reasonably well. And so they're not so densely amblyopic and irretrievable as we had thought. So I do them all the time now because they're lying there anyway and they might as well have the second eye done, which they don't use. It's wonderful for uncooperative patients. All of these people volunteer to have their pictures. People that have psychiatric problems, Down syndromes and others, people that have like Duchenne dystrophy where you can't move them from their chair very easily and take a long time to position. I do a lot of anesthesia class 4 patients, patients who aren't expected to live more than 5 or 6 months, but unfortunately have cataracts sometimes from their chemotherapy and would like to be able to at least read for the last 6 months of their life. They're extremely grateful and they're very rewarding. And then you have people that are hard to position, which are also much easier to do both eyes at once than to do 2 different operations. My main suggestion is if you do bilateral surgery, be careful. Don't take anything from the first to the second eye. Read over these suggestions we have for excellence. I personally make one of these handwritten charts and put it on the microscope for every case so I know which person I'm doing, which eye I'm doing, which intraocular lens I want for that eye, and if I'm going to rotate it, the axis of astigmatism or whatever, if it's toric. And I make sure that when the circulating nurse hands the lens to the scrub nurse, she calls out which patient, which lens, which eye. The scrub nurse then announces the same thing as she gives it to me, and I look up at the microscope and make sure that it's in my handwriting, that I have checked which one I'm getting. And in doing that, I have yet to make a right to left error in 12,000 or so eyes. And make sure all of your staff are aware of how to do bilateral surgery before you start doing it. Next thing, I think it's critical to use intracameral antibiotics. There have been endless studies of over 10 million eyes showing how effective they are. They reduce the infection rates by a factor of about 4 or 5. And they cost very little. Even in the United States, it costs $20 per eye. which is by far the most expensive country in the world. In Canada, it costs about $1 or $2 per eye. In India, it probably costs still less. And you save patients from losing their vision, and it just makes your life a lot easier. Beware about myths opposing bilateral surgery. People will come to you and say, well, I don't do bilateral surgery because you might get bilateral postoperative endophthalmitis. Well, we found in our society and looking at the world literature that the only cases they have had of bilateral endophthalmitis have been in patients where there was no sterility protocol followed. There was a serious breach of sterility. But if you don't do that, if you follow our suggestions and use antibiotics, the real risk of getting bilateral endophthalmitis simultaneously is about 1 to 2 or 300 million, which means about one patient in the world every 10 or 20 years might get bilateral endophthalmitis, doing our 20 million cataracts per year around the world. And then there are all these arguments about improving the refractive result if you modify your IOL choice for the second eye. It turns out it's just not true. If you use ultrasound, it might be true. But if you use our new biometry instruments, IOL Master or LensStar, and you do topography to check the cornea, and you use one of our modern equations, it just never happens. And I haven't had to change a lens or do anything to correct anybody in the last 15 years. So it's not a reasonable worry. If you talk about bilateral surgery, please use the terminology that we've approved. And that's because I endlessly get articles to review and I can't understand what they're doing because they make up their own terminology. There are some quotes that I like, and one of them is from John Bolger, who had a course we gave at AIOS in 2008, basically reviewed the traffic accident mortality in London where he lives. And he said, when people are worried about the 1 in a million risk or less of getting bilateral endophthalmitis, he tells them that the risk of driving to the 3 extra visits in London from their home, when he judged about the average distance, how far they live, the risk of dying in a car accident is 3 times as high as the risk of getting bilateral endophthalmitis. The difference is that endophthalmitis you can treat. Death in a car accident you can't treat. And so he said you just balance your risks in life, but you always take some risk, but it's best to have it minimal. And Olivia Lee published an article in the AJO showing that the risk of bilateral endophthalmitis is about 1/2000th the risk of dying from general anesthesia. So it's not particularly high. People weren't doing it before because they, in many jurisdictions, were getting paid more to do both eyes separately. And now they want to do it because they find they're being reimbursed better by doing both eyes together. So COVID-19 is changing perceptions, but we hope it's not for the wrong reasons. The need to wait between cases is changing attitudes. And in many places, in many jurisdictions, you can do almost double the number of cases as bilateral surgery as unilateral surgery. And so numerous groups now are trying to go to their governments and to change the funding models to allow them to do bilateral surgery. So the rationale behind bilateral surgery really is that what we're doing is we're fixing the visual system at one sitting and not one peripheral receptor. It's better for the patient, it's better for the family, it's better for society, and the global risks of everything are a lot less in doing bilateral surgery rather than unilateral surgery. The documents for the ISBCS are now stored on the Eye Foundation of Canada. So you can either go to ISBCS or Eye Foundation of Canada and you can find anything you want. Bilateral surgery is increasing rapidly around the world, spurred by COVID-19. If you're going to do bilateral surgery, whether you do extracapsular surgery or you do phaco or femto, please follow the general principles of excellence, which are now accepted as a global standard. And the reasons that have been proposed not to do bilateral surgery simply have not been verifiable in any studies. The risk of endophthalmitis occurs only if you don't follow our principles and don't use antibiotics. And the need to adjust the second eye IOL power just never happens if you use modern instruments. The real issue is money, and COVID is changing our perceptions of what perhaps is best for the patient. Thank you very much. It's a great pleasure to be invited as a speaker, and I look forward to the rest of your session. Thank you.
Thank you so much, Dr. Steve. I think over to Dr. Maipal, sir, for his comments.
Well, excellent, Steve. I know that you are really one of the people behind promoting simultaneous surgery, and I think Cyrus Mehta is also part of the group that is there. I have I have really no studies to say whether simultaneous bilateral surgery would increase the incidence of endophthalmitis, things like that. But I think there is a certain norm that is there, and one has to actually change that norm, because in today's world, God forbid, at least in India, if you do something which is against a convention, a settled convention, and something happens to the patient, that itself can drag you to the consumer court, and it can be said that you are doing something which is against the normal ethics or normal ways in which you are doing that. But I'm sure that as the outcomes improve, we are doing bilateral simultaneous surgery in LASIK or any refractive surgery that is there. Some people have started doing it in ICLs. But there are very few people who are doing in India as things stand, and there are very few proponents. So I think you will have to come and keep on showing more evidence to do that. The only thing is that apart from one other thing that you mentioned, which is the optical biometry, etc., I think unfortunately, majority of the Indians don't have an optical biometer, and because of the stage in which our country is as regards development, a lot of us are still using the immersion or the A-scan as things stand. So therefore, the surprises could be a little more. And there are instances, especially in the camp settings or in high volume centers, where off and on we get these examples of 8 eyes, 12 eyes, 16 eyes, or 20 eyes getting endophthalmitis still. So I think until, of course, one is very, very sure that all the equipments are getting changed, one is very, very sure about the sterility of the whole thing, one is very, very sure about the outcomes of one surgery, and one is very sure about the IOL power calculations and how the patient is likely to behave with those IOL power calculations. It will be, I think, a slow and a gradual process in India. But I think very well articulated, scientifically supported talk that you have given. And we'll have people discuss it out on the panel. I don't know if anybody else in the panel or among the scientific committee members are actually doing the bilateral simultaneous cataract surgery. Thank you for an excellent talk.
Quick question from the audience.
Sorry?
A quick question from the audience. Will you do a multifocal or a trifocal as a bilateral simultaneous cataract surgery? Dr. Steve?
Actually, I will only do them as bilateral surgery, because when you do them as unilateral surgery, they notice difference in contrast in their two eyes and they complain. When you do them together and the patients have, imperfect vision before, which is why you're doing surgery, they are really extremely happy. And whatever you plan, whether you plan both the multifocals to have the same focal points or a bit of monovision with them so you have more progression, they are really very accepting of the result, much better. So I actually will only do them as bilateral surgery.
Sonu, so one of the ophthalmologists who is doing bilateral surgery, Dr. Bharti in Delhi, he does it only for the trifocals or the bifocals. And that's exactly the reason what Steve is saying, that he doesn't want to expose them to two different types. So one of the indications where he's doing together is for these premium IOLs.
Can I
see like summation, right?
I think Dr.
Vision in 2 eyes, there's summation, so you see better with 2 eyes.
Thank you, Steve. That was an excellent presentation, and I'm on the same board as you are. And for last many years, I've been doing the same simultaneous in multifocal lenses. I have presented at some forum also, but I get the same kind of a criticism. And these are the two main points that you have said. And you have rightly said that once you have standardized your procedures and your protocols for biometry and your protocols for operation theater are standardized and followed, I don't think there should be any hesitation in going ahead with. And thank you so much for a great presentation.
Thank you for your comments. I love your red turban.
Thank you.
I just had
Thank you very much.
Partha, I just had a comment to make. I think it makes a lot of sense now, especially for pediatric cataracts who have total cataracts and you have GA coupled with general anesthesia. So if you do them bilaterally, maybe that time is also decreased, especially in the corona times.
I think,
Partha, can I make?
Yeah. Steve, thank you so much for, basically opening up a subject that is at a particular time controversial, but not really so, because you have shown world literature, you have shown your own experience, as well as the experience of so many other places, other countries who have developed the sequential bilateral cataract surgery. And it is a lot of food for thought for our own country. Apart from what Dr. Grewal said, the important cases of the multifocals or the trifocals, or what Namrata said about the cases of the pediatric cataract, we in India used to have a huge backlog of needless blindness because of cataract. And that is one huge segment that possibly we should address. Now, going by the parameters of the sterility, the procedure, and the infection rate, I think uppermost in everybody's mind is the infection possibility, which deters a surgeon from a bilateral cataract surgery. What happens if? And that if is what deters us specifically. However, as the results mount to show that cataract surgery has become safer and safer, and the world literature, as well as Dr. Haripriya's literature from our own country, which showed that the number of endophthalmitis post-cataract surgery has gone down dramatically because of the use of intracameral moxifloxacin, and most of us are using intracameral moxifloxacin routinely. So here we definitely need in our country a study that shows whether bilateral simultaneous cataract surgery is the way to go for our cases, which are our charitable cases, the ones who cannot pay and for whom we actually cross-subsidize in our hospitals. So that is the segment with what India should be looking at. And here I'd like to ask Dr. Haripriya if you would like to comment on it, because since Aravind Eye hospitals do a huge number of charitable cases, and what is your take on a bilateral sequential cataract surgery in the socioeconomic?
So again, thank you, Steve. The second time I'm listening to your talk, the first time was at the Ophthalmology Summit last year, and I think after your talk, we have more reasons to believe in performing immediately sequential bilateral cataract surgery. So actually, we have not been doing it routinely. We do it in people who have psychiatric illness and who need it under GA. But besides that, we haven't done it. And like you mentioned, probably this pandemic is one reason we may have to consider, at least for some patients, because we're seeing many more patients with advanced cataracts now. So over the last 3-4 months, we haven't been doing many surgeries. So we have patients with bilateral mature cataracts. So this probably is a good time, at least to start off with those patients. And like was mentioned, maybe it was not for everyone, but if we can choose those patients wisely, especially if they have advanced cataracts in both eyes or both eyes require premium IOLs, I think they would be the first group I would consider, rather than the patients who are coming from the camps and things, because as was mentioned, with our optical biometers and stuff, the refractive outcomes have been so good. We find that, we never actually adjust the second eye's power based on the first eye, because the outcomes are very good today. Except for a research purpose, we don't actually adjust the second eye unless you have 1 or 2 cases where you have some significant errors. So that makes sense. We also saw that amongst our data, we looked at last 7 years as data to look at timing between both eyes surgery. It was about 300 days. So that was a long time that the patients were only having uniocular vision. So much more higher chance of anisometropia, in terms of safety, the quality of living. So I think somewhere either bilateral simultaneous, or even if it's delayed bilateral, at least to do it with a less difference, more consciously, I think is something we have to consider. Thank you, Steve.
Oh, thank you. Can I make a comment? What I've observed being on the outside is, most of us who give lectures around the world, we go all over the place. So you see how different countries are doing. And I think that if I had to be positive on the economy of one country, it would be India. I think that you guys have come amazingly long way since I first went there in the early 1990s. And I think you will have continued enhanced success. And I think things like the camps will slowly disappear as India becomes gradually more affluent. And you also will find that the money that you save by bringing someone in from far away and doing both eyes together can then be spent on something else you're doing in bilateral surgery, like paying for an IOL master when you'd be doing thousands of cases anyway, so the per patient cost is not very high. You'll find that gradually you move to those things, and the cost will become irrelevant, and the camp patients will disappear. They'll be poor, but they'll pay a little bit to help cover their costs. And so I think, like in other countries that have found the same thing, you will gradually move in that direction. The same as I think that you will slowly move from manual small incision to phaco and femto as India becomes a more affluent country. And you have the youngest population that's educated in the world. You have a very dynamic country. You know, in Canada, we have something like 23 places that teach ophthalmology. And I think in India, you have 1,640 or something. It just boggles the mind for a Canadian to come to India and see how many wonderful surgeons and great ideas you have. If you go to any meeting in the world, most of the new ideas and new videos come from India. So I can only be extremely bullish on the prognosis of how well you guys will do. And I don't think claiming poverty will last very long. I think you will find that that just disappears, and you will have success upon success upon success. And I just love coming to India. I think it's a great country. You guys do wonderful work, and I'm really honored to take part in your meeting. Sometimes I wonder why you ask me, because you have so many fantastic Indian surgeons and so many fantastic universities. Why have a little guy from Canada where we have no universities compared to you and very little research compared to you?
I think we are waiting
thank you
for
very
the day when you guys start calling Indians, and then we don't need to call you back.
Actually, Steve, I debated against you in a WOC debate just day before yesterday, and yes. I spoke for delayed sequential bilateral cataract surgery. So quite a few points are still fresh in my mind. Of course, you have very strictly laid down criteria, but once in a while, I know there are only 6 cases of bilateral endophthalmitis that have occurred, but all of these have been reported by the secondary centers where the patient went for treatment. So obviously, just because this is the incidence, this is what has been reported, we cannot consider that that is all the incidence of bilateral endophthalmitis, which is obviously be a disaster. Apart from that, bilateral TARS, bilateral macular problems, which have gone undetected. And once in a while, still we come across cluster infections in camps in our setup. Obviously, that would be a disaster if both eyes have been operated. And as regards premium intraocular lenses, even though we hit the target most often with present-day formulae and instruments that is available, even if we hit the target in the first eye, very often I titrate the power, the type of lens that I put in, micro monovision, etc., depending upon the comfort level of the vision that has been achieved in the first eye. And bilaterally implanted, I find that I'm able to achieve much better results when I give a 2-week gap and titrate the kind of power that I'm implanting in the second eye. It's not a mistaken biometry, but learning from the first eye to implant in the second eye. So basically a great talk. I've listened to this before, but just giving a contrarian view to just round it off.
Well, thank you. I don't disagree entirely with your concerns, and I can tell you that all of us who do bilateral surgery went through similar concerns. But I'll tell you with confidence that as you do more and more bilaterals, you'll find that your views change, because they do extremely well. As long as you're careful, the risk of infection is negligible, and the chances of errors become less and less as you use modern machines and you use topography to check out the corneas or tomography to check out the posterior surface as well. You find that you just don't have those mistakes, and the patients almost invariably are seeing 20/20 post-op and with a multifocal they can read, or trifocal, and they're quite happy. They see better with 2 eyes than with 1.
Thank you very much, Steve, and thank you for the wonderful discussion. I know you have 2 more webinars to attend today, so we won't hold you on, but we'll definitely have you for more debates in India.
Okay, well, thank you very much. It's been a great pleasure as always. Yeah.
Thank you, Steve. Thank you for accepting our invite. Thank you so much.
All right.
So as we move
the
on
rest
now,
of the webinar.
I'll take this opportunity to invite the next speaker. Next speaker is Professor Rajesh Sinha. He's Professor of Ophthalmology in Cornea Lens and Refractive Surgery Services at RP Center, AIMS, Delhi. And he's a prolific writer with 300 and close to 350 publications, 3 textbooks, and 4 educational manuals to his name. He's been a part of 3 multicentric FDA clinical trials and has received achievement awards at American Academy, Asia Pacific Academy, and SARC Academy of Ophthalmology. Delivered many notable orations in the country. He's an excellent surgeon, wonderful human being, and a very close friend. Over to you, Professor Rajesh Sinha.
Thank you.
So the panel, Dr. Namrata Sharma, I invite Dr. Haripriya and Dr. Namrata to please panel this debate at this talk.
Thank you, Dr. Partha and Dr. Sonu, and I'm extremely thankful to both of you for inviting me in this webinar. I'll be talking about managing cataracts in hazy corneas. And the biggest problem with hazy corneas is the issue of visibility. Is the issue of visibility, because the cornea is hazy and a surgeon wants a clear visibility for proper cataract surgery. So the aim of doing the surgery in these cases and the aim of presentation is to enhance visualization and try to find out ways how to enhance visualization. And one of the important ways is to use tap-in blue dye for a slightly longer period in these cases so that you can stain the anterior capsule well. And while you are doing a capsular excess, you have an opacity here in this area. So you should be careful that you don't leave the capsular flap somewhere behind this. You should leave it behind a clear cornea so that you can hold it properly and create a nice circular capsular excess. And good hydro procedure and rotation is very essential because it is only partly visible. So you need to do that carefully. And by chopping technique, you can complete the nuclear emulsification. And once you have done the nuclear emulsification, while you're doing cortical aspiration, you should ensure that the tip of the irrigation aspiration probe should always be visible so that there's no, you don't damage the capsule accidentally. And if you catch it, it will be difficult to leave it. Now, use of viscoelastic on the cornea many times helps in increasing visualization in many cases. So is the case with the use of endoilluminators, which really improves visualization while you are chopping and while you are emulsifying these nucleus pieces. And once you've emulsified the nucleus, to hold the EP nucleus, the margin of the EP nucleus, you can take the endoilluminator inside, you can very nicely see the margin of the EP nucleus while you're holding. And then you can bring it in the center and emulsify it and completely aspirate it. So these endoilluminators are really very useful in performing procedures. Again, chandelier illumination is another good technique in hazy corneas, which will give you a nice red glow, and you can go ahead and do a capsular excess and the other steps of emulsification. Sometimes you have a very hazy cornea like this. In that case, you would like to do anterior lamellar keratectomy. You would like, if the opacity or the haze is in the anterior corneal stroma, then you would like to do an anterior keratectomy. And once you do it, many times you see that the cornea clears up very nicely, and you can go ahead and perform the cataract procedure in all sorts of cataracts because the visibility has improved quite significantly. Once you have done you're done with the cataract procedure, you can replace the keratectomized cornea, like with whatever thickness you have removed. So if you have removed a thickness of 150 microns, you don't need to put a suture. But if you have removed a thickness of more than 200 microns, then you need sutures. In cases wherein you have a central corneal opacity like this, even a pupil of 5 to 6 millimeters is not good. Because you can see only from the peripheral part. So it is essential to enlarge the pupil further to 9 or 10 millimeters by use of iris hooks. And sometimes you can do a eccentric crater. Dr. Namta, one of the panelists who gave this idea of, and we have a paper also which we are sending, of doing an eccentric crater and chopping. So in such cases, if you have a central corneal opacity, after completing the procedure, as you can see in this case, you can do a small sphincterotomy. Professor Tital knows this. We had published this article. So you can do a small sphincterotomy, and that gives a nice visual outcome in the patient for a on a long-term basis. So a case of corneal opacity, something like this, and one-eyed individual, vascularized opacity, risk of graft rejection is there, procedure. You can do a cataract surgery by enhancing visualization safely, and maybe a little small pupillary sphincterotomy to provide a long-term, reasonably good visual outcome. Thank you very much.
Thank you, Dr. Rajesh, for a wonderful presentation. I think Namrata madam is here. I think you are mentioning her that she is the person, I think, done a lot of surgeries with hazy cornea. Madam, your opinion.
I think it was an excellent presentation, Rajesh. You showed virtually everything and such difficult cases to handle. So the question I think that generally comes to our mind is how do you calculate IOL power in such cases? So would you just throw a light on that?
You can use, if the patient is, the other eye is fine, then you can use the cornea of the other eye to calculate the keratometry and the axial length of that same eye. So that way we can have IOL power calculation. If the patient is one-eyed, then in that case, maybe a standard K can be taken, and one can...
I think a question which comes to every phacosurgeon, not cornea surgeon, I'm saying essentially a phacosurgeon, is when you encounter a case of Fuchs dystrophy with cataract, then what is your cutoff for the endothelial cells? To be whether you will just continue with phaco alone or you'll think of a transplant.
Yeah, this is definitely a tricky situation, but if the cornea is clear and the endothelial cell count is more than 1,000 per square millimeter, and the corneal thickness, central corneal thickness, is less than 640 microns, then in that case, it is advocated that you should go ahead and do a cataract surgery first, and then see in subsequent follow-up whether the patient requires endothelial keratoplasty. Now, only thing is that if if the values are on the other side, like if the endothelial cell count is less than 1,000, thickness is more than 640 microns, in that case, a combined procedure is considered as a better in terms of providing good visual rehabilitation. Now, the only thing is, if you are doing a DSEC procedure, planning a DSEC procedure, then there is a risk of hyperopic change in these patients. So if you're planning that, then you should err for, if you're doing a cataract surgery first, then you should err for a slightly myopic target refraction, something between 1.25 to 1.5 diopters, so that subsequently, if you have done a DSEC, then the hyperopic surprise is neutralized by the myopic target refraction that you have taken. But in DMEC, if you're doing a DMEC and regularly do it, and you're sure that you can do it, then you may just go ahead with an imetropic path.
Haripriya madam, I think you might have been doing the similar type of surgeries in your place also, Arvind Hospital. But I was very impressed with the Rajesh presentation on the chandelier illumination. So I just want Dr. Haripriya's opinion. Will you follow the same technique, or will you do some other technique, or you do like endo probe illumination what Rajesh showed?
I haven't used the illuminator, but I think Dr. Rajesh's video was very comprehensive. So he covered all the options of how different options of dealing with this. So what I would do is I would try to maximize the visibility. Obviously, we have access to good microscopes. We obviously will try to go with the red reflex mode to do the capsular access. I'd also tilt the eye so there is more illumination in the eye. So try to see through the clearer part of the cornea where it is possible. Again, the pupil size also matters, like Dr. Rajesh showed, using the iris hooks, because once the pupil is smaller, the red reflex goes down significantly. So to enhance that, you may even consider using some rings or hooks, so you have your larger pupil. So these are the different tips I would use when dealing with eyes with hazy corneas.
I think one more point which we can discuss, and that is, you should do phaco in situ. One, what happens is if you have a very hard cataract or a wide cataract with the corneal haze, and you don't have a retro illumination on, then it can get a little bit tricky. So in all those cases, when you start the case, you put your retro illumination on. I mean, ensure that it is on. True is that phaco in situ. That means as you chop, eat, so that the orange glow gets better and better, and it becomes clearer as the orange glow gets better. So phaco in situ is important rather than leaving the chalk pieces there only, because with the passage of just eating away the nuclear fragments, the orange glow becomes wide, expands and gets wider, and the rest of the things become clearer.
Another factor is also with the capsular rhexis, I would like not to start or end at the site where you have the opacity, away from it, because once you complete, you're sure that way that you have complete capsular rhexis. So I'd like to pass under the hazy cornea somewhere midway. That's something I would consider.
Tityal sir wanted to comment, I believe.
Yeah, just two comments in this. Cases with corneal opacity or corneal scars or a hazy cornea, where we are going to do cataract surgery to improve their vision, should be those cases where you have opacity little paracentral, or they are not in the visual axis significant one. If you have a large opacity in a visual axis, whatever you do, you're not going to improve vision significantly in a post-op for these patients. So I would consider those patients where central area is relatively clear, or they have a nebular macular type opacities, where your keratometry can be done nicely and you have a good IL power calculation. In fact, I had written a little bit on this also. If you have a larger opacity, one-eyed patient where you have keratoplasty may not be a feasible option. In those cases, to avoid the major complications, suppose you're doing phaco in these cases and you have a nucleus drop, the things become tough. Though I think nowadays we have an endoscopic surgery, you can still do a good vitreoretinal surgery. In such cases, SICS surgery may be more safer. That will not have a more chance of the nucleus drop in such cases. And Rajesh covered most of the thing, but I think the endothelial protection in such cases are much more important. You're going to have more damage in these cases because surgery is going to be much difficult. So what Steve was there in the beginning, his technique of soft shell techniques should be used in these cases, not in the beginning also, and maybe in between also when you have difficulty. So I would consider, people should consider what they're going to achieve after surgery and take those cases where vision is going to improve. Otherwise, if bilateral cases, I would never take them for a simple cataract surgery. Maybe plan for a triple procedure if you have a larger opacity in the center. Using all those devices to improve visibility may work out. But if you have significant opacity, I think Namrata will also agree sometimes lamellar procedures can be done in these cases to have a better visualization and subsequent optical clarity.
So, Partha, can I make a point? Partha?
Sure, sir.
So actually, again, the same discussion as we did with Steve, it depends upon where you are, what kind of equipment you have, and what kind of expertise you have. So it is obviously going to be dependent on the availability of the corneas, and it is also going to be dependent on the outcomes that you are getting with a graft. Now, sometimes the corneal opacities can deceive you a lot, both in the form of nebulomacular corneal opacities, us thinking that they will not get good vision, but patients at times become very, very happy. The second thing that we need to see is that in case we have superficial nebulomacular corneal opacities, on the skill sets, the academics, the surface ablation is something that can be done as a PTK mode to kind of smoothen out those, which is possibly more predictable than a graft. And the third thing is that what Rajesh was saying, I fully agree with him that there are these parameters that you would want to have a cell count of 1000 and 640 being the cutoff. But again, there are several times pleasant surprises that you get. I have operated on patients with counts of 600, 700. It is not just the count which matters, but it also depends on the structural, apart from that, the functionality of the cells that are remaining. So often in young individuals with even lower count, they have performed well. I still, there's a patient under active follow-up who's a magistrate in one of the Delhi courts, and I told him that we will go in for a combined because his cell counts were almost like 500, 600. And the chief judicial magistrate, he said, no, I am very afraid. I don't want to get a DSEC with a cataract. And to my surprise, the patient is having 6/6 vision. And this is almost 1 year post the surgery that, and he's giving judgments and he's very active on that. So what I'm just trying to say is that at times you do get deceived by what your count is showing on the specular, because it may not be totally aligned to the functionality of the endothelial cells. So may or may not be a bad idea to give it a shot of doing a cataract surgery first. And if the cornea decompensates, obviously the patient is prepared, and in a short interval, maybe a couple of weeks or months, you could go ahead and do a graft for these patients, a lamellar graft. So cornea at times is deceptive, both in superficial opacities as also in endothelial cell count.
Completely agreed, sir. Actually, these are just guidelines, but there are many cases wherein, things behave differently, and it's always, practically better that, in such cases like cases of Fuchs, we do cataract surgery first and then see how it behaves and then go ahead with the subsequent.
I think wonderful points by Dr. Mahipal, and thank you, Dr. Rajesh, for that wonderful presentation. I think a single video gave all the teaching pearls. Thank you so very much.
Thank you.
So next we have Dr. Gaurav Luthra. I don't think he needs any introduction. The face of AIOS. So let's hear from Dr. Parikshit. Dr. Parikshit.
Yeah. As you rightly said, Dr. Sonu, Dr. Gaurav Luthra needs no introduction. One of the most popular figures in AIOS. He's been the chairman of ARC for IIR-SI, and of course, the backbone of the Uttarakhand State Ophthalmological Society. And he's done a lot of phenomenal work in Dehradun Drishti Eye Institute, and he has been member of both the ARC and the scientific committee of AIOS. But more than that, he's known as a dear friend and a mentor to so many of us. To Dr. Gaurav sir.
Thank you so much for the kind introduction, Dr. Sonu and Dr. Parikshit. Can you hear me? Can you hear me?
Yes, sir, we can, sir.
Okay. Or just I'll introduce Dr. Chettial as the panel and Dr. Devbasi.
Sure. I'm so sorry. I'm so sorry.
Thank you so much, sir, for accepting our invite. All to you, Gaurav.
Thank you. At the outset, I'm grateful to AIOS and the AIOS Scientific Committee and the chairman for inviting me for this prestigious webinar. And I've been enjoying all the excellent lectures so far, and will continue to enjoy them. I'll quickly share my screen. All right. I was asked to speak on intumescent cataracts. It's mostly going to be video based, and we all are dealing with this. All of us, I think, and most cataract surgeons actually have this, challenge of the intumescent cataract. So the challenges with the intumescent cataract could be many. At the outset, shallow AC, high intralentricular pressure. They could be upthrust sometimes in these cases, especially glaucoma patients as well. Runaway rhexis is always a risk that you're always scared of. So you're trying to make sure that you don't have one. Sometimes you can have the rhexis redundant tag prolapse through the incision, and that can be a challenge. And with the escaping viscoelastic, they can be a flag sign. So several, innovations have been made, or whatever. I mean, people have gone through the, so many ways of managing these intumescent cataracts. We use ample use of viscoelastic, of the correct viscoelastic, the soft shell technique, yagging the anterior capsule. I was listening to this yesterday in one of the webinars. I added it here. I personally don't do that. Decompressing the lens, which I think many of us are doing now in different ways. A small quick rhexis followed by aspirating a little bit and then enlarging the rhexis. Punctorhexis, as popularized by Dr. Mohan, but much before that, even by Uday Devgan and so many others. Spiral rhexis, which again is a wonderful technique, and I'll be showing one of those. Zepto can be used, and even the femto-assisted, which has probably become a very popular way of managing intumescent for those who actually own one. So these are so many ways that we can tackle it. I wanted to start by this one video. As you can see, I do use a rhexis marker, and then I stain it with the trypan blue. Now here we were managing an intumescent. We didn't anticipate that this would cause problems in our estimation. So we are going with the conventional way of doing our rhexis. Otherwise, I would normally follow a different way. But you can see that suddenly now there is this beginning of an extension. So I quickly go from the side port, try to aspirate, but just watch what happens. And this is the reason why I wanted to show this video. Sometimes if you're trying to decompress, if you suddenly aspirate, it can catch the capsule and the rhexis tear can actually extend. So this can cause problems, and then you can of course try to manage it, but if it runs away completely, then you're in a soup. So when using all these aspiration techniques for decompressing the lens, one has to be very careful that use a very fine cannula and make sure that you don't get caught with the capsule doesn't get caught or sudden decompression doesn't happen. Now, another situation where we are dealing with the intumescent cataract, and this didn't appear again to be a problem, but as we reached near the main port, and you can see here that suddenly the viscoelastic escapes and the flap tends to come out. And I'm sure some of us have held this problem, and it can be dangerous because it can cause a runaway of the rexus. So at this point, you have to be very, very careful. You can manage this redundant flap carefully, push it back, or you can snip it if you have some kind of good scissors which can go through and put in more viscoelastic to let it go back. Sometimes putting in viscoelastic can be counterintuitive because it can actually bring the flap further out. So you have to be very, very careful that you don't let this run away. And then once you manage it, of course, you can go back and finish the rexus, and it's not difficult to manage, but this does require care. And now, in spite of all these things, when you have an intumescent cataract, sometimes, you are fearing that the moment your rexus is, you're fearing that it can go into a flag sign, which sometimes it does in spite of all your best efforts. And then, you have to kind of make sure that you manage it adequately. And one way which I talked about initially, and which is one of my favorites as well, is to, of course, you can, aspirate and do that, but a spiral rexus, making a smaller rexus first, and then this is a slightly fast forward video, so please excuse that, it looks fast, but you have to do it very carefully and gently and slowly. And you can first make a slightly smaller rexus like that, and then you can go and actually, once you've completed one round of the rexus, a small one, a frill of rexus can be, you can keep doing it and it'll never run away. So this is one thing I've learned over the so many years that I've been doing these patients, that even pediatric cataract with intumescent lenses, if you have that small frill, it is never going to run away, and you can take 3, 4, 5 rounds, as many as you want. So you can see here that I've almost completed maybe 2 or 3 rounds, and yet, it has given me the adequate size rexus. So what I currently do is this, stain the capsule, put viscoelastic. I try to use viscoat because it works well for me. I've done the soft shell and everything else. Dr. Arshinov is here and we'll take his comments on that. But once I've done that, you'll notice that I'm not going through the main port, but I'm going through a separate new paracentesis to decompress the lens. And let me just show you how it works. So stain it. And once we've stained it, we will make sure that we have adequate viscoelastic there, and you can see that this is an intumescent brown cataract. Now, making sure that all ports are sealed. So my side ports, my main port, everything is sealed so that the chamber cannot be lost. So I'm taking a 26 or a 30 gauge needle from the new port. There is no chance of decompression or leakage. I'm sorry. Yeah. So I'm just decompressing and aspirating. Now you can either go bevel down or bevel up as is your comfort, but you have to be sure that you don't catch the capsule and do it gently. And once you've decompressed the lens, you can obviously complete the rexus very easily. And this is what I prefer to do today. But let me show you the challenges with this as well. And here again, we are doing this decompression and aspirating, and you can see that aspiration worked. Then I thought that it needs a little more decompression, went in from the side port and did a little more, making sure that viscoelastic is replaced each time. And then you can do a quick small rexus, because here I felt that, the mid periphery was still intumescent enough that I was worried that it might run out. So here again, I went with the spiral technique, and believe me, this really works well. So all those who are listening in, whenever you're in a situation like this, make a small rexus, and then, you can make a bigger one. And if it just completes as a small rexus, don't hesitate to give a small snip on it, and then make it larger, make it adequate, because see, this is a brown cataract. If you have a small rexus to deal with, you're going to have problems cracking the nucleus. So please don't settle for a small rexus. If it completes accidentally, then please go around and snip it and then make a bigger rexus, and it works quite well. Now, sometimes these things don't work, and you can see here that there is a situation where this was a very intumescent cataract. We went in with the technique that I prefer to use now, and I aspirated. I'm so sorry. Yeah, in spite of all the experience with the webinars, I'm still making these mistakes. So here it aspirated a little bit, decompressed, but see what happened the moment I went in. Now you can see that, I'm just entering to inject visco, and this has started running away. So even the slightest decompression can cause problems, and you have to be very, very careful that the chamber remains stable at all times. And then, I'm just using the cannula to just reflect that small flap, and then of course you can complete it. So these are the situations, but now just watch what happens. I was very nice and happy after giving one oration on intumescent cataracts. I thought I've achieved it all. And I said in that oration that in 300 cataracts now with this technique, I've never had a flag sign. And when I came back first OT, I had this patient, just watch what happens. I have done everything right so far, and I'm going into, make the decompression. And once I, you know, manage to go in, just watch, I'm in now, and I'm just going to start aspirating. And as I start aspirating, I just touch the lens there. Just watch. I just touch it. And before even I have time to do anything, so sometimes if you've done everything right, in spite of that, sometimes this will happen. Now, what is the key? The key is to do an OCT pre-op. I've started doing OCT for all my intumescent cataracts. And if you see these clear fluid spaces just behind the capsule, you have to be fully prepared. Second thing you should be looking at is the AC depth and the lens thickness. So if you can look at this, if you have an AD of like less than 2 millimeters, you have to be extremely careful. You can look at the convexity of the lens, and you can look at the lens thickness. If it's more than 5.5, these are situations. So today I do femto assisted surgery. I'll just show you quickly and then we'll finish. Once you do the scan, yeah, I'll just finish in 30 seconds. I won't show you details of the surgery. So all I wanted to show was that in a femto, which is currently my favorite technique for those who have access to a femto, it is very good to be able to do this. And you can pick up the intumescent cataracts, you can pick up the AC depth, and then you can still get away with a good surgery. You can see that. Just watch the mushroom as the laser fires. You'll be able to appreciate what happens in an intumescent. Just see how that explosion takes place. And yes, I would like to just point out, I'll conclude that femto is not fail-proof. I still manage to occasionally get tags in the end of the surgery. And I also manage to get sometimes a broken rexus, but the percentages are really small. So the take-home message is that please, if you have access to an OCT, please do an AS OCT. Please make sure that you're watching the AC depth and ensuring that the convexity of the lens is under watch. Use viscoelastics correctly. Make sure that your chamber remains stable all the time. Decompress the lens from a separate port, rather not from the main port or the side port. Have good control, good instruments, good micro-rexus forceps. Go only from the side port. And if possible, if you have access to a femto or something, that would be a great idea as well. Thank you so much.
Thank you, Gaurav, for a wonderful presentation. I think we have here Professor Tithial. I think I still remember he's been showing the intumescent cataract with the help of OCT guided system, who is accessible in RP center. I think we want sir's opinion regarding the intumescent cataract management.
First of all, Gaurav, wonderful presentation, classical videos, a lot of teaching tips. I think there are a few things that are important in white cataract. First is your analysis of morphology or type of white cataract which you are going to tackle, which Gaurav talked about, anti-segment OCT. The careful straight line examination, anti-segment OCT will delineate what type of white cataract you are facing with. So if you have as you showed in the OCT, if you have an anterior capsule and there's a space between the anterior capsule, there's a homogeneous space, those cases will be amenable to your puncture, because you have to decide there are two ways to decrease the interlenticular pressure, raised lenticular. One is puncture aspiration. Second is doing a small opening, a small rexus, then aspiration. So these two ways you can decrease the interlenticular pressure in these cases. So I would say those cases where you have a lot of space between anterior capsule and the hydrated cortex, that means you have a fluid in between. Aspiration with the needle can safeguard these cases. If you have a continuous sheet of hydrated cortex and you have an intra-laminal fluid pocket, those cases you may not be able to aspirate. Their pressure may not decrease. Those cases we should do a small rexus, then aspirate. So this is the morphology pre-op can give you. Second important thing is the viscoelastic which you are going to inject into these cases. I normally do a combination viscoelastic, which is a reverse Arsenov technique. First, I use a coercive viscoelastic, that is 1% sodium halonate, make a chamber uniform. Over that, I inject a dispersive viscoelastic so that it maintains the coercive viscoelastic tamponade onto the anterior capsule. When you are doing a nick, there's no sudden decrease in the pressure and you don't have an extension of tear happening in these cases. So you can easily manipulate the capsule with the 1% sodium halonate in these cases. And third important thing is as you nicely showed, do a small rexus, decrease the pressure, then do a spiraling technique that works wonderfully in these cases. Even after you complete your nucleotomy, if your rexus seems slightly smaller as per the IOL said, you can again redo the customization of rexus after you complete the nucleotomy also. The same thing yesterday I talked about, same thing in WOC also. The question is to check your pre-op morphology of your cataract, white cataract, then visualize what type of difficulty you're going to face. then implement that on the table. You don't require IOCT for all the cases, but if you have, that can give you a much more dynamics of how much flattening or anterior capsule happening. After you make a nick, what happens to the peripheral cortex. Other important thing which we nicely sold by Dr. Gaurav, if you have a tear seem to extending to periphery, don't jerk at that time. Slowly take out your needle or a capsulotomy forceps, then try to inject the dispersive viscoelastic from periphery to center so that the tear doesn't go periphery. So give a pressure from periphery so you tamponade that area which is going to tear out, and that will decrease the tear extension immediately. One or two cases I could prevent the Argentine flag also. As soon as I saw that tear is going to elliptical shape, I made a cruciate incision. That means 4 incision into a cross one. The pressure changes to 4 direction. That also decreases the pressure. Give some time for making smaller opening. So I would say if you understand cases pre-operatively nicely, you can manage in an intra-op phase also. But beautiful videos, Gaurav.
Thank you, sir. Thank you. Grateful from the master. If I hear it, it really makes my day, sir. Thank you.
Dr. Devashi, sir, your comments on the intumescent cataract?
Yeah, I think Gaurav made a wonderful presentation and was followed excellently by Professor TTR's remarks. I also prefer the reverse, option of technique. I use heavy viscoelastic, maybe Hilon, and then go with the visco-dispersive viscoat. And the point of interest is the infralenticular pressure factor has to be more neutralized in the periphery. So I generally top the periphery more with the dispersive viscoelastic. So that is one thing I would like to share here. And the other thing which we were talking about is basically where the entire lens is hydrated and the chamber shallow and the lens thickness beyond 5 millimeter. So here the other option I would definitely consider is to debulk through a pars plana vitrectomy. So that makes things much more easier, especially if we are doing some kind of premium eyewear. And the other thing is how to retrieve back a rhexis when it has gone peripherally. One is, as of course TTL said, that slowly reconstruct the chamber from the periphery to the center with a dispersive viscoelastic. And then, generally we try to continue or retrieve the rhexis back in the direction of the rhexis, but I think it's better thought that we retrieve it towards the center and in the opposite direction. But because the pull is already there, I think this has become quite a standard technique now. And of course, in intumescent cataracts, we also have to follow certain rules about the nuclear management, because often you would have a sclerotic small nucleus after the rhexis has been done. So we need to hold it at one part and see how well we can chop it. And then, of course, we have to use the heavy viscoelastics to deal with an empty capsular bag or a lax posterior capsule, which keeps on flapping, and of course, reduce the parameters at the end stage of when the nucleus has been taken care. I mean, at the end of towards the end of the phacoemulsification. These are a few things which help us do our job well. And we've been doing intumescent cataracts. I mean, everybody has to do, and it keeps on coming our way. But Gaurav's presentation was excellent. So was Dr. Tityal's remarks. Hope we learned quite a lot.
Thank you, sir. Thank you. Thank you, Gaurav. Thank you, Dr. Tityal. Thanks, Dr. Devasis, for getting these points. We did a small survey, and you would all agree for the last 3 months, everybody is facing with these white intumescent cataracts. So the basic point was to get these for all practitioners so that they would be giving their results to the best of their abilities. Thank you so much. Now we have Dr. Shreyas Ramamurthy. who would be presenting this case on black and brown cataracts. And I'd like to invite Dr. Amit Porwal to introduce Dr. Shreyas.
Good evening, everybody. Am I audible?
Yeah.
Yeah. Thanks, Sonu, for the invitation. So, Dr. Shreyas Ramurthy is a consultant in cornea, cataract, and refractive services at the Eye Foundation in Coimbatore. He's got special interest in laminal corneal surgeries, including dark DSEK and DMEK, mucous membrane grafts, stem cell transplantation, and keratoprosthetic surgeries. Topo-guided instrument treatments, Contura LASIK, SMILE, phakic AIOS, and he's got 28 peer-reviewed publications. He's a gold medal awardee for AIOS at 2017 and at an AIO meet in Pune conducted in 2018. He's completed his FICU. So over to you, Shreyans.
So we invite Dr. Grewal, welcome sir, and Dr. J.K. Reddy as the panel for this wonderful video that Shreyas is showing us. All to you, Shreyas.
Yes. Thank you, Amit sir, for the kind introduction, and I'd like to thank Sonu sir and Partha sir for having me here. So today I've been asked to talk on cracking the brown and black cataracts. I don't have a formal presentation, but just a couple of videos which I'll keep under 4 minutes. So I'll start off with the case directly. So this is a grade 4 to 5 nucleus. And this was a patient who was also wanting a toric multifocal lens. So you can see the toric markings in place. Trypan blue is something definitely which we use in these cases as you don't necessarily have a good red glow. And using a good viscoelastic is always helpful. With regards to the capsulorhexis size, I like to make it slightly larger than what I would in my traditional cases because it helps in even if you're not able to chop it wonderfully and if you have to extract larger pieces, but at the same time, not too large that you don't have an overlap over the lens. Doing a gentle but multi-quadrant hydro is extremely important as any aggressive movement of this nucleus can cause zonular dialysis in these cases. I do a central trench. Now, the length of the trench is not necessarily very important. It's the depth which is more important. But a central debulking always helps as it provides more space. And it also helps you to occlude deeper so that your first chop can go right up to the crater itself. Now, this chop in these hard cataracts, because you don't want too much lateral extension, may not go right or across to the entire extent to the other end. So rotate the nucleus by 180 degrees and then go on to chop at a deeper level till the central spine is broken down. Again, you can do the same things, occlude, and again, keep chopping. As you can see, I keep going deeper and deeper till it is chopped right up to the center. Traditionally, what is being referred to as a multi-level chopping. You start a little more superficial, but keep going deeper till you're right up to the base. I'll talk a little bit more about the emulsification in my second video, which I'll be showing. But suffice to say, it is important that you have chopped it down into multiple pieces before you go ahead with the emulsification process itself. Subsequently, there is usually very little cortex left in these cases. I go ahead with the IOL implantation here. Like I mentioned earlier, having a large capsulorhexis is helpful, but again, it should not be too large, especially when you're doing these toric or multifocal lenses, as you need a uniform overlap, as you can see in this case. And subsequently, once the lens is placed, it's important that you do a complete viscoelastic removal from behind the lens. And before I remove the irrigation cannula, I position the lens, hydrate the opposite ports so that there is no sudden shallowing of the chamber. Hydrate both ports so that the lens is perfectly in position. Moving on to this next decidedly darker and blacker nucleus. The pupil is also slightly smaller in this case. I do a gentle multi-quadrant hydro, just summarizing the points which I mentioned in the earlier case, and ensure that I have a good rotation. Now here, as you can see here, I'm making a really deep central crater so that I can embed as deep as possible so that I can crack the spine of this hard nucleus. Now, as you can see, I go ahead with a horizontal chop, and as I do it, it's only the half nucleus right up to the center which is cracked. I rotate it by another 180 degrees, go ahead, and then complete the chop right up to the center. Now, even when you lose a hold, it's important that you let go ahead and grasp it again, and then continue your chopping. you will not be able to chop right up to the very depth, probably in your primary chop in these hard cataracts. So it's important that you keep separating, going deeper at a multi-level and ensuring that the last bit of fibers are also separated. It's important that you have a complete separation before you start emulsifying the pieces, because any premature emulsification or any premature attempt to remove the piece into the anterior chamber can cause excess stress on the zonules. And it's important when you start removing the first piece that you ensure that your capsular rhexis margin, you have a look at it and ensure it's not tilting in one direction, because any excess maneuvers during your chopping procedures can cause a little bit of zonular dialysis, and you have to be exceedingly careful that it does not extend during the residual part of your phacoemulsification. Towards the last pieces, one important thing to keep in mind is that the phacoemulsification needle can actually bore through the density of the nucleus, and you have to make sure that your nuclear piece is not above the tip of your phaco needle. You have to ensure your phaco needle is always above the nuclear piece, and there is a sufficient nuclear piece below your phaco needle so that the phaco needle is not directly exposed to the posterior capsule. These are just some of the simple tips that I follow for dealing with these dense nuclear cataracts. I hope you all found it useful.
Fantastic presentation, Shreyas. I think you have showed most of the difficult case. I think as Sonu was mentioning his previous presentation, now all of a sudden after this COVID era, I think we started getting grade 4 cataracts, mature cataracts. I think very nice presentation. I think Dr. Grewal sir is here. I think he's been always promoting for like premium lenses even in case of a harder cataract. I want his opinion regarding this.
You will have to unmute, sir. Sir, unmute. Grewal, sir.
Is it okay? So thank you so much, KP, and thank you, Shreyas, for great surgery and good tips that you have given in the surgery. It's important, the capsulotomy, if I would prefer that to make an oval capsulotomy in these cases with a long access along the main incision that gives you a greater space to work with your phaco-tip. You were right that hydrodelineation, hydrodissection should be minimum because it's a big hard nucleus. You don't have much space to work for it. The first chop is very, very important, and I would prefer to make a wider trough, a deeper trough, and going just up to the center. It should be short, not too long, so that you have enough of the bulk of the nucleus left to hold and chop. And I'll prefer to have the first fragment very small and then have a little bigger fragment, because if you make your first fragment a little bigger, it becomes difficult to pull it out. And I would like to proceed to the first only after I have been able to have the nucleus divided into two complete halves, as you said, to break the backbone. Again, I'll say good presentation, excellent presentation, and good point. Thank you.
JK, the innovator, my friend JK Reddy is here. I think I want his few comments on this. JK?
Thank you, Dr. Prasad. And Shreyas has done a wonderful videos. It's a superb surgery, and he's demonstrated very well how to handle a very hard cataract, which we are seeing post-COVID, as mentioned by many speakers. We are seeing most of this type of cataract, mature cataracts and brown cataracts nowadays. A little bit, it looks like he's more favorite of horizontal phaco, and he's using classical Nagahara chopper in his videos. But most of us try to like our vertical chop in hard cataracts. I'd like to know the panelist opinion. Dr. Ritial, sir, do you like vertical or horizontal in a hard cataract?
I do a almost similar technique which Shreyas had shown in a very, very hard cataract. I do a not only trench, I do a crater and leave the peripheral part of a nucleus. So making a hard central core nucleus into a grade 3 or 4 subsequently, then do a vertical chop. I don't do a horizontal, I do a vertical chop and then separation and try to reach right up to the posterior plate. And he demonstrated beautifully in the first video. Was very, very nice teaching tips in that. And I normally would say like in these cases, sometimes the energy goes too much. So you need to have a repeated, Ashnov technique in these cases. I begin with soft shell technique, then subsequently titrate if my, the energy goes CD goes beyond 20 or 30, then I do another soft shell technique, especially when I have done a multiple division of nucleus and then take out one by one. And that is the time we require a soft shell technique. Some cases you lose the epicortical cushion in these cases, you hardly have sometimes. They're also giving a viscoelastic tamponade to a posterior capsule also important in these cases, because by the end of a surgery, because a big nucleus, your posterior capsule becomes very floppy. And you have a machine, you have a little bit of surge, you try, you cast the posterior capsule towards the end. So that precaution we need to take. So I think the separation right up to the posterior plate is the key for a success in these supra hard cataracts.
I just want to make a comment, Kudlu. I think excellent videos. I just want to highlight one of the facts, and that is when you do these hard cataracts, then there are little small fragments. As you finish the case, sometimes you don't see, and those fragments, they tend to be there, near the side port or just behind your main wound or at the iris tip. So when you take out your instruments, it is important to address those fragments. And later on, you find out that they are stuck there, and then you have to address them with the help of viscoelastic gel, push them in the center, and then
Just
again.
one, sorry, madam.
Yes, I'm done.
No, just one question, or rather a question and a comment. I myself have keep switching between these two. That is, traditionally, a lot of people say to remove the pieces in these hard cataracts so that you get more space to work with while evacuating them. But I actually find it more difficult to chop once there is a lot of space in the bag and the nucleus becomes more mobile, and it actually becomes even it keeps twisting around in your phaco needle while you're trying to chop. So I actually like to complete all my chops in these cases. I just do that central crater to give me enough space to have that separation, but subsequently I like to complete my chops. Just wanted your views on it.
Yes, Suresh, you are absolutely correct. That is what I told also, because these nucleus are very, very large, and the amount of force required for separating pieces can be, significantly much more. So if you have one area which you have eaten out, that area is free, then tilt of a nucleus happens when you're trying to chop in these cases.
Absolutely.
The best is when the bag is completely filled, whatever pressure you're going to distribute in the entire bag. So that is the time you separate all the pieces, make a multi-chop technique, which is nicely demonstrated, then eat one by one. Or even you have a small attachment in the center, doesn't matter, because you can take all the pieces, and at the end it becomes very easy. It's like a hypermature cataract where you don't have epicortical support. You have to have a division first, multiple divisions. Otherwise, you're going to have a difficulty and more chances of bag dialysis happening in such cases.
Debashish, sir.
Yeah, just wanted to make a quick point. To preserve the dispersive viscoelastic in place throughout the procedure, I go on a continuous irrigation. And here, there are steps where you use a lot of energy, and there are steps when you are not doing anything. You are trying to relocate and align the probe with the fragments. So during that, I go to foot position 0. And so there is no aspiration. So in that way, you actually keep the viscoelastic, and the corneal protection on. So I just wanted to make this.
Last comment from Dr. Ramamurthy, sir.
Yeah, I think all of them have been talking about direct chop, and that's what Suresh also showed. So at the cost of sounding a little old-fashioned, I'd also like to submit that, stop and chop is also a great technique in these cases. In the sense that, especially some of these leathery cataracts, it's a little difficult to chop. And in these cases, the downslope sculpting, where most of the phacopower is deep in the lens and well away from the cornea, though significant amount of energy is, you can literally make out that you can create a trench deep enough so that you can introduce two instruments and completely divide the cataract into two hemi-halves and under direct visualization. And once you have broken the spine, the rest of it becomes a little easy. So really hard mahogany cataracts, and where I feel there's a significant leathery element, I feel that doing even a stop and chop would be a good idea, a good alternative.
Cannot agree more to Ram. Cannot agree more.
हम भी वही कह रहे
हैं. Good technique.
All old-fashioned guys.
हम भी वही कह रहे हैं, Ramamurthy, we do the same thing. पहले बैकबोन तोड़ना जरूरी है.
I think femtolaser also gives a very significant advantage, especially in these dark cataracts. And Dr. Chi has also done some work where she has shown that you don't actually need to actually repeat the passes of the femtolaser. I think Professor Chi, maybe you can say that what you have found out, that even a single pass is good enough to have a cut there.
Yeah, so with reference to the use of femto using the Catalyst platform, sometimes they would ask you to have like a repetition of the passes for your segmentation. And if you did that, that would increase the amount of energy and the time, and that would create a lot of gas production within this very hard and thick nucleus. And it may not be so safe when you have a very, very thick cataract. So actually, I found that with 100% of the energy, the maximum energy that the catalyst can provide you for fragmentation, you just do a single pass and you just do 8 segments, and that is able to very quickly segment your nucleus with very little gas production.
So, quick comment if I can make. Sir, excellent video shares and very nice chopping techniques that you have demonstrated. I also do the direct chop. The only small tip that I would like to give for this is, most of the time the plate does not get severed, and that is the time where you need to use a little more energy, and it doesn't come tumbling up, and the little pies are all stuck together. One technique that I had already demonstrated, chop and harvest. Harvesting means to hold it with high vacuum, lift up that small fragment and go manually with the sharp chopper and just sever the fragment, so that it just gets severed, and then you just eat up that piece with very little of energy. So very small technique, but it really works very well even today.
You mean in the later part of the phacoemulsification, when you're left with that plate, you're saying?
Yeah, when it's left
lift
with
it up and slice it.
Yes, yes.
Thank you, Shreyas. I think a wonderful presentation and a wonderful learning pearl from all the masters. So now we have the much awaited keynote address, and Professor Chi Soon-Fik. Dr. KP, are you there?
Yeah, I am there. So no, sorry for the interruption. I think it's a pleasure to introduce Professor Chin Sufai. Actually, she is the head of UVA Ocular Inflammation, head of Cataract Research Group, and also I think mentor for advanced training in ophthalmology, and also professor in the Duke National University of Singapore Graduate Medical School, also fellowship director Singapore National Eye Institute. Probably she got most of the awards. I think I don't want to tell every point of her biodata. I think we have been keep meeting her in every conference. The best part of her, I think, as our president Maipal sir and even Titial sir said, that we keep learning from her every time whenever she come to the conference. She got the best teacher award in SNEC, and she has got the presentation almost every conference, and she has got the award from, I think, starting from Asia Pacific, I think starting from APAO or APCRS, she got the best paper award. And she has got a 27 publications, I think, starting from Asia Pacific Journal of Ophthalmology till the Journal of Cataract and Refractive Surgery till 2012. Over to Professor Chin Sufai to hear from you. She'll be talking about mastering mastering the zonuloplasty. Sorry that I was just out of the internet connection in between. And our moderator for this particular keynote address, none other than Professor Jivan Titial sir, also, and Namrata madam. Over to Chinsu madam.
Thank you very much. Let me share my slide now. I hope you can see the screen.
Yeah, perfect.
Okay, so first of all, I'd like to thank the AIOS for kindly inviting me. And Sonu kindly helped me to choose the topic to speak on, because he said, you all like to hear about zonules and the absence of zonules. And in particular, he told me not to talk about femto because many of you may not have access to that. So let me just start. I have no financial disclosures of relevance to my talk today. And clinically, when you see a patient with weak zonules, phacodonesis, it's important to determine at the slit lamp the site and extent of the zonular weakness, right? So it's important to lie the patient down, especially if you do not have a UBM access, right? So if you see a patient upright, you may think that this patient's got good vision. Why is he complaining? But when you lie him down, you realize that lens is no longer in the same anatomical position because it's actually got no zonular support. And usually when a lens does something like this, more than 180 degrees of zonular dehiscence is present. Now, if you do have a UBM, you don't really need to lie the patient down to examine him because this test is done with the patient lying supine, right? So it's very, very useful. It can tell you the extent and whether the zonules are completely gone or partially gone. So you can actually tell also the location and the number of clock hours. So you have a patient here with intact zonules, and we know the anterior, equatorial, as well as posterior zonules, and you can examine for its presence. So if some of these are missing, you know it's partial zonular dehiscence. You can also detect the presence of vitreous if you're not examining the patient carefully at the slit lamp, right? And in a case like this, there are really no zonules here. What are the capsular support devices that we have available to us? We have a plain tension ring, or you have the Bonnie-Henderson modification where you don't get trapping of the cortex after its insertion. You have modified tension rings for suturing. You have a 1-point fixation, or you have 2-point fixation. And then you have these add-ons that are very, very useful that I use all the time, especially the capsular tension segment. You can add 1 or you can add 2. And recently, to add to our armamentarium, we have got the Susan Jacob paperclip capsule stabilizer for a glued capsular hook. And then we have the ASI anchor. So how do you decide what devices you need? Really depends on the extent of zonulitis, the strength of the remaining zonules, whether this is a static or a progressive disease. And generally you go by 4 clock hours, all right? So if you have 4 clock hours missing, then you can just insert a CTR. If you have between 4 to 8 clock hours of loss, then you basically need 1 point of fixation. And you have more than 8 clock hours, definitely you need 2 points of fixation. And what devices you choose really depends on what's available to you and what you're comfortable with. And sometimes it also depends on the particular case, what is convenient to use. So what is important is knowing what's the difference between iris hooks and capsular hooks, because we use them for different purposes. So in the case of iris hook or a capsular hook, both do provide suspension of the capsule in the anatomical position. They center the back, but iris hooks, unlike capsular hooks, they do not support the equator of the capsular bag, but they do provide capsular traction when you're doing a capsulorhexis like this. So this is definitely better to use a hook than a capsular hook, an iris hook than a capsular hook. And you can also use this to invert your hook and support the capsular tension segment eyelet. So for example, if you have no access to a capsular bag hook, you can actually use a capsular tension segment, which you suture in later, but you can use it in the time of phaco to just support the equator at this area. Suture material, generally we propose the use of stronger material than 10O polyene, so we use 9O, or what I use routinely today is actually 7O Gore-Tex. It's CV8, although it's 7O Gore-Tex. It's off-label use for scleral fixation, and it's got excellent longevity. So I know I've presented many times the use of my suture snare technique, and I know many of you are very confused because you see so many sutures running around. So I thought, well, if I just showed you this bare capsular tension ring, this modified with a 1-point fixation, the Sione ring, and you have a Gore-Tex or a polyene suture already preloaded onto this. Now, if you think of how you're going to get it to your scleral fixation point, what would you do, right? So this is just to introduce to you the concept of a lasso. So I thought, well, if I had a suture here that I could thread through the end, I could just lasso it and I could pull it back out at the scleral fixation point. So if you put the eye in place there, right, this comes into the scleral fixation point, and if I were to pull it, basically, I will be able to retrieve the suture here. So it's really a very, very simple concept, and you can look up this paper. So this is a case, a dense cataract pseudo-exfoliation syndrome, and I'm just looking around. It said actually zonules were intact, although weak. You know, these are the most difficult cases. They're small pupil, and you can see, well, the zonules may look like they're there. You can see the pseudo-exfoliation material. But really, you know, they give way during your surgery, especially when you have a dense cataract like this. So the shallow, I had a very shallow anterior chamber. I decided to just put a hook to provide the counterforce, and I'm using an iris hook here. Right, it's a very black cataract. I did not want to use vision blue. It won't help me that much in providing contrast, but in addition, I didn't want the dye to stain the vitreous. All right, so I'm providing the counterforce as I go along. So now I've completed the rexis. And a very important step, putting viscoelastic just under the capsule to create space for the insertion of a capsule tension ring, a plain ring, right, just under the capsule, clean dissection of the capsule away from the cortex. And now I know my equator is expanded. In addition, I'm providing more support by these hooks that support the equator and very short vertical trench. I impale. I like to do horizontal chop. Right? It can be a bit tricky if you don't know where the equator was. And that was the reason why at the start of this case, I used the Coughlin hook to look at the equator. And at the end of that, before you come out, important to maintain the anterior chamber and then insert the IOL. And you will see that I had no cortex that was trapped. Now, if you have very weak zonules, it doesn't matter, you just mark anywhere 180 degrees apart, and then a Hoffman pocket, and now I insert a preloaded capsule tension segment. This is a cortex suture segment, and I'm just positioning it there in place. Now, very important, I've already pre-threaded this needle, which is a 27 gauge I used today, right? I'm pulling out this lasso that we showed, putting the end of the suture through and pulling it out, like what I showed you with the lasso, right? Create the space when your needle comes through. You don't want to puncture that bag that you had been so careful in preserving, right? So this is the lasso. I'm going to repeat it exactly the same on the other side. I find the use of the MSC faucets very, very useful to help me in positioning rather than Sinski hooks where the segment can spin around, right? So make sure that when you come through, you don't puncture anything, and that is done by putting viscoelastic so that you create the space between the iris and the bag. And so this is the lasso coming out through the main incision here and pulling my suture out now from the Hoffman pocket. It's important that the pocket's dissected deeply enough because you do not want exposure, erosion and exposure of this cortex suture. It will cause a granuloma that you have to go back and patch or exchange for a different material or suture. All right, so the tension is also important to ensure your RL is well centered. Okay, so let me show you the next case now. I have 3 cases, so this is my second case. So now we have another complex case. You can see everything is shaking and it's white and intermittent. So it's very nice that we had all these talks that went before, right? Fortunately, it's important, perhaps a pearl for you, when you don't have a zonular attachment, actually there is very little tension on the anterior capsule. So there's less risk of this running out. But I'm now providing the counterforce, which if I didn't, because there are no zonules here, it would run out, all right? So I then complete the rexis of the appropriate size, and you can see the shape is a little collapsed. I again inject the viscoelastic. In fact, every case, whether it's white or black, it's the same technique, right? Inject the viscoelastic, creating the clean plane. Don't be happy until you have the clean plane, and then inject the CTR. Okay, now I know my equator is kept expanded. I put in the capsule hooks that provide further support, and then you can crack right through. All right, it's a little leathery, although this is white on the surface. And you can try to minimize your rotation, and this is how I like to take it out. And you see that in all the surgeries that I do with this, I do it in a very similar manner. Chopping, sometimes you can't rotate, you impale to rotate the nucleus, all right? You swivel the nucleus around, and you can see actually I don't have a red reflex, and that's because I had stained the capsule. And now I notice that this has slipped off in my attempts to crack. Now this I'm going to show you a little complication because I had done all my cracking movements, that hook had slipped off and the little vitreous strand came forward. And you can see I got no good red reflex there. And I think I'm getting fluid misdirection because the hook had come out, I had not noticed. So I put the IOL in first before completing my surgery. And I'm going to show you Sergio Canarava's technique of using Prolene. And this is 6O. I've pre-threaded it. Nowadays, I don't thread it on the needle. I actually thread it through the needle as it comes in the eye. But this is just to show you with the capsular tension segment. The flange has been created and I'm then positioning it. So this is 1.75 mm posteriorly. I pull out this 6O Prolene. I thread it through the capsular tension segment, make sure it's large enough so it doesn't slip through. And I'm not very happy here because I had some vitreous coming through just now. And so I'm then doing the vitrectomy here, right? Both behind as well as amputating one that come in front. And at this time, then I insert the capsular tension segment and apply the traction. And it's important that you apply the traction first before you decide on what length, usually about 3 mm length for the diathermy. And then make sure that this is really covered by conch nicely. And at the end, you can insert some triamcinolone and then remove any residual vitreous. This is the final case I'm going to show you. It's a difficult case. You can see less than 180 degrees of zonulysis. We start with vitrectomy because there's vitreous lying in front of this lens that is dipping posteriorly. Right? You want to remove adequate, but not too much because it does support the lens. This vitreous behind does support the lens. And with the 27 gauge needle bringing this lens forwards, I then catch it at where the capsule was slit. And with a bimanual technique, right, you want to use forceps that are not sharp. Okay, so I started with the capsulorhexis forceps. I then continue with 2 MST micrograspers. And as you go along, you can start to support the capsule, the whole lens at the capsulorhexis, and at this stage, it's okay to insert this capsule back hooks, and I then switch everything to capsule back hooks so that the equator is now supported. We set that plane between the anterior capsule and the lens, and then insert a plain CTR. Hydrodissection, this is much softer cataract. Okay, so we're doing a stop and chop here, cracking right to the base, and then cross chopping. Okay, so that we don't really have to do any rotation, tumbling out the first piece, the next piece. All right, you can just tumble all these pieces out. And because the dissection was adequate with the viscoelastic, the CTR does not trap your cortex. Insert the IOL into the capsular bag, showing you again the suture snare. You can use a 26 or 27 gauge needle with a short segment of the cortex suture, creating Hoffman pocket. In this case, I was actually going to put in a toric IOL here. And you can then introduce the suture snare, 1.7 mm posterior to the limbus, and then bring the end of the suture loaded on the capsular tension segment through to the scleral fixation point. We repeat this. So now both sutures are there, and we repeat it for this other segment. So if you watch these three, they're all very, very similar, just that, you know, we had different extents of zonular weakness, different densities of cataract, one white, one black, one dipping into the vitreous, but really they are all the same. Okay, So you can see in this case, I just use two tension segments and CTR. This really makes it easy because if you had a only one L, you would have to keep rotating the eyelid to the right place. Okay, here you can insert the capsule tension segments without rotation, no torque, no stress on the rectus even. And even if it's a slight tear, you can still use. Okay, so this is just to show you the end of this section. So these are my pearls I leave with you. If your lens is anteriorly subluxated and patients present with high pressure, right, I always run IV mannitol. For white cataracts, I always run pre-op IV mannitol. This will shrink the vitreous as well as the lens, all right, and very often will save vitreous presentation and deepen the anterior chamber for you, right? You need to be very careful when you use trypan blue, as I showed you the second case with the white cataract. The vision blue actually went to the back and stained the vitreous. It makes you lose that good red reflex. It helps you in the surgery. If you see vitreous in the anterior chamber, you must always deal with that first by manual CCC when there is actually weakness. That's very severe, like what I showed you in the third case. Use capsule back hooks because they support the equator. All right, iris hooks, as I showed you, can actually help you in your capsule rexus, support a capsule tension segment when you don't have capsule back hooks. Delay the placement of a CTR in general, but in cases like what I showed you where there's severe zonulisis, I like to place it first because it expands the equator, and when you hook the bag up, basically you close off the space between the anterior chamber and the posterior chamber, so you don't get fluid misdirection and you don't get vitreous presentation. You inject the OVD just below the anterior capsule and the CTR in the space. This is very important so that you don't trap cortex. And in all three cases I showed you, no cortex was trapped. All right, this is the key, right? I was asked not to show you femtosecond laser, although I do this quite commonly in these cases where the pupil dilates well, and really with the lens fragmentation, you have dense cataract. These really help to make the case so much easier. Thank you very much.
Thank you, Professor Chisu. And I think once again, one of the fantastic presentation. Can you hear?
Yes, I do.
Yeah. One of your pearl, you are talking about the dealing with the vitreous in the antechamber. Do you use triamcinolone acetate whenever you do vitrectomy, or just to do like that only?
No, I always use diluted TA.
Yeah.
Yes. It's important to use it.
Thank you, Professor Chi, for taking our message, because we just wanted at large to society to benefit, because not everybody has an access to the femtocataract. And we know that both work very well, or I'll say manual works very well under your, the surgery, the kind of surgeon you are. Amazing presentation. So I would request Professor Dr. Tetyal and Dr. Namrata Sharma to please have your comments on the spellbound surgery that she has showed to us.
I think there is nothing much we can add to what Professor Chi has shown us. She's been a wonderful surgeon and a good friend of ours. And the videos were classical, the teaching tips. But I have few points to make as far as general surgeons are concerned. We have to really know what is the basic pathology behind these subluxated cataracts. I normally would not like to leave the bags in a disease which is progressive, like ectopia lentis cases, or you have a hypermature cataracts, like you showed one pseudoexfoliation, or a chronic degenerative disorders, or vitrectomized eyes, where the bag may not remain stable for a very long time despite fixation sometimes. So if you have a gross subluxation like you showed us the third case, I might take the bag out in such cases and do a transcranial haptic fixation of IOL, which may be more stable for long term. Otherwise, the surgical tips you showed was very nice. The suturing technique you have made look so simple, but I normally I don't get into those difficult situations. I'm lucky I'm in an institution where I have friends who can take care of these cases. I have Rajesh Sinha, my colleague, who takes care of all these cases where I don't have to do a fixation at all. So those are, I think, difficult cases, but very nicely managed.
Thank you.
Fantastic presentation, I think. I just wanted to ask you a couple of questions. One is, you mentioned toric intraocular lens implantation in these subluxated bags. So do you routinely do, and do you think your results in terms of misalignment are any different from cases where the bags are normal and they are not subluxated, especially the
Uh,
toric?
Not really. Some people believe that if you insert a capsular tension ring, it would actually stabilize the toric LL and reduce rotation rates. So I have not actually seen these actually rotate. I do that for Marfan syndrome even, where the bag may be even smaller, and that lens is really squashed and it does not move at all. It doesn't go anywhere. So actually, I also put in. I think I was asked during the WOC, someone said, I saw you put in a multifocal lens. Is it safe? And, are you sure of your calculation? Well, I don't use a trifocal lens because we know that we need to be very precise with trifocals. But I use an EDOF lens so that even if I'm not exactly, in the plane that we predicted the ELP to be, because it's difficult to predict the ELP in some of these cases, especially if they're anteriorly subluxated or posteriorly. So I rather use an EDOF lens if the patient is young and wants some kind of presbyopia correcting IOL. Yeah. But I've had good results with these.
And how do you decide where you're going to be using Gore-Tex or where you're going to be fixating it, with the Proline and not using Gore-Tex, or it's just, random?
Okay, so I used to use Proline, but once I started on Gore-Tex, okay, what you see is really done very quickly. I thread my Gore-Tex suture through my needle, and my colleague can attest to that. It's like 5 to 10 seconds. Okay, but there are some tips when you thread it. So firstly, when you cut that Gore-Tex suture, you need to cut it at an angle so that you have a sharp point. And that threads through a 27 gauge needle very easily. Secondly, your fingers must be dry whenever you handle the Gore-Tex. The moment it is wet, it becomes limp and you cannot thread it. So I always make sure my fingers are dry when I handle it, and I stretch it when I cut it so that I get this sharp point, and then it goes through in seconds. Okay, so actually I find that once you have the ability to match and mix, whether it's a CTR or a CTS, I prefer to use a CTR and then add a CTS anywhere I wish to, and I can add 2 instead of 1. So I don't worry now whether I have 6 clock hours, 8 clock hours, or how many clock hours. These are guides that people ask for, all right? But if you have available capsular tension segments, you just add a CTR and you think of it, well, when I'm doing my surgery, I don't really want this eyelet there. I just want to expand the equator, all right? So you just add in a CTR. And then when it comes to the time where you need to fixate, you say, well, where is the area of greatest zonular dehiscence? Now, if you had a Sony 1L, you would say, okay, I need to put it there, but I have to rotate. And I don't have enough counterforce when I'm trying to rotate something that is severely zonulized. So it makes it difficult to do, all right? So what I do is I just slip in the CTS and insert it exactly where I want it. And very often when I put in the capsular tension segment, I will test it, all right? Especially if I'm only having 1 point of fixation, I'll push it to the equator and see whether that centers my IOL. And you will notice that I always put in the IOL before I put in the capsular tension segment and fixate it. Because it's the IOL that tells me exactly where the bag is, because the IOL will always center on the bag. Okay, I don't look at the rexis, even if you scan the capsular bag, with the catalyst and all that. It's not 100% accurate. I can tell you that for sure. Okay, I've been played out by the catalyst, when I've done the scan. So I actually tested out with the capsular tension segment. Is this the best place if I'm just going to put 1 capsular tension segment? So if you push it here and no, my IOL is not centered, then you say here, and you say, okay, this is perfect centration. And then I mark my spot for fixation, and that's where I create my Hoffman pocket. But if you have 2 points to fix, it really doesn't matter. Okay, I just put it diametrically opposite. It doesn't matter where you do it. Yeah.
Excellent tips. I think those were great tips in the whole of your presentation, as well as the discussion thereafter. Excellent.
I think the one, initial tip you gave, examining the patient on a supine position is a very good tip. Sometimes we do never see these patients in a supine position. That's only on a table. Then you realize you have, such a large subluxation. And pupil also doesn't dilate most often that well. And as soon as you inject viscoelastic, then you realize you have a larger subluxation. So that's a very nice tip to examine patient supine position and do a UVM. I think that should be a one thing people should take home. Do a UVM and see the status of an entire general complex. Very good tip.
Thank you.
Thank you, Professor Chi, for that wonderful presentation once again. And I think all members would benefit from your wonderful pearls. So without taking much time, I would now like to request Dr. Shel Vasavda. And to welcome him, we have Dr. Feroz. Dr. Feroz, are you there?
Yes. Good evening, everyone. I hope I'm audible.
Yeah, loud and clear.
Program so far. So I take this immense pleasure to introduce our rising star, Dr. Shel Vasavda, who's a cataract and refractive consultant at Raghudeep Eye Hospital, Ahmedabad. I have known Shel as a meritorious resident who made one of the excellent talks in the Potodia of LV Prasad Eye Institute. And we have seen him grow as an excellent surgeon and academician, many feathers to his cap. He went ahead doing his cataract and refractive surgery fellowship at Moran Eye Center in United States of America. Further to that, he has been bestowed with various awards, and few of them to stress upon. He has won the best paper at AIOS in 2015. Congratulations, Shel. And one of the recent one is the best video at ESCRS in 2019. So we are very proud of all your achievements, and we are looking forward to your talk and your work. Thank you.
So I would like to invite Dr. Nasir Shroff and Dr. Ramamurthy sir for being the panel for this talk. All to you, Shel.
Thank you very much, Dr. Feroz, for that wonderful introduction. And I think the times that we shared at LVP are the most memorable in my life so far. And once again, thank you very much, Dr. Sonu sir and the AIOS Scientific Committee for this kind invitation. I'd like to acknowledge the contributions of my colleagues, Dr. Samresh and Dr. Vaishali in creating this presentation. At the outset, we do receive research grant support from Alcon Laboratories, but has no relevance to this presentation. So after all the brilliant surgeries by the previous speakers, I'm going to show not so much brilliant surgeries which end up in iatrogenic complications. So this was a case which apparently seemed to be going off quite well after chopping. Fragment removal was being attempted. The first fragment was being removed. And you can see not a very dense cataract, grade 2, grade 3 kind of a cataract. The eyeball, if you notice, is just moving a little bit up and down, but the surgeon seems to be doing quite well. After having removed the first couple of fragments, this was noticed, which retrospectively in the video, which the surgeon didn't notice and went ahead with the fragment removal. The centration also not being great, so probably visualization or attention was not being paid at that point of time. So you have this nice little iatrogenic hole or in the capsule that has already been created with 3/4 of the nucleus still in place. And the first thing that we want to do in this situation is not to pull out the instruments. So keep noticing the foot pedal here. We go back to foot. Now you go back to foot pedal 1. Then make sure that you inject dispersive viscoelastic before you withdraw your phaco probe so that the chamber doesn't shallow. So we will all encounter this complication, if not in such a simple case, maybe in a more difficult case. And the most important thing is to keep calm and not to panic and not to withdraw the instruments. Once that is done, now we need to assess the extent of the posterior capsule rupture identify whether vitreous is already present in the chamber or not, and also start preparing, keep telling your OT assistants to start preparing, keep looking for the backup three-piece IOL, which may, or a scleral fixated IOL, which may be needed eventually in this case. Like Professor Chi showed, triamcinolone is of extreme importance in diagnosing the presence or looking for the presence of vitreous. And very often we feel
When
there
the
is no
vitreous
vitreous
phase
is
is
not
disrupted,
present in the chamber, but when you actually stain, you do find vitreous coming even as close to the main port or the side port. The second question is when to do vitrectomy. Do you try and remove most of the nucleus? Do you try and delay it up to the cortex removal? Are you fearful that if I do a vitrectomy now the nucleus will drop? The answer is we need to address the vitreous whenever you notice it. So it could be in the beginning of the surgery before starting the case, it could be in the middle of the case, it could be at the end of nucleus removal. So you have to address it as and when it is required. And one thing that we always forget is that we always feel that this nucleus is just, in the area of PCR, there's only little bit of vitreous. Let me first go and remove that with the phaco probe, otherwise it will drop. But what we forget in that, while in trying to attempt that, is the tremendous amount of vitreoretinal traction that we are causing at the vitreous base. So it may not appear to be causing too much of problem, and you may feel that you have gotten away with that. But what the consequences it leaves behind to the periphery of the retina is something only our retinal colleagues would be able to tell us. So it's something that should never be attempted, that if you find a fragment sitting on a PCR or sitting in wrapped with vitreous, don't go with the phaco probe to try and remove it. And this is an excellent video shared by my vitreoretinal colleague to show why we should never do that. This is a drop nucleus, and notice how much it is entangled all around by the vitreous. And think of it as if you would go and attack this with a phaco probe. Think of the amount of damage that we are going to cause to the peripheral vitreoretinal base. So therefore, it's very, very important that we first address the vitreous before actually thinking about touching the nucleus. Now, the second goal of now having decided to do vitrectomy, the goal is to prevent acute intraoperative vitreoretinal traction and salvage the eye, and not to try and salvage the sinking lens material anyhow. So if it drops, follow the bye-bye technique, let it go and let our colleagues take care of it. They can do a much better job than what we can do. As an anterior segment surgeon, our goal is to prevent further enlargement of the PCR and try and provide a symmetrical scaffold. And we have two approaches to do that, the limbal being the more familiar to us. But this beautiful animation experiment by my colleague Dr. Samresh showed that when you actually do a vitrectomy from the limbal approach, you tend to pull in more vitreous from below, actually enlarging the tear, versus when you drain the vitreous from the pars plana approach, you are actually attacking it from where it's coming out. So you are draining it from that hole. So you're not actually pulling up on more vitreous and lesser chances of the posterior capsular enlargement. And also it allows for more symmetrical vitreous removal. With the limbal vitrectomy, ergonomically, it's almost impossible to remove symmetrical vitreous from around the posterior capsule tear, and therefore you would have pockets of more vitreous on one side or less vitreous on the other side, which can lead to tilting of the bag and eventually of the IOL. And compare that to the pars plana approach, where you have great ergonomic access all around to remove vitreous symmetrically or all around the posterior capsule tear. So coming back to our case, the first thing that we want to do is to stain this area with triamcinolone, and sure enough, there was plenty of vitreous which had already prolapsed into the anterior chamber. We prefer going through a trocar because that will allow ease of frequent removal and insertion of the vitrector, but you need not necessarily need a trocar. And notice how this entire bulk of vitreous has drained beautifully. So I'll just replay that. Notice this chunk of vitreous has drained down beautifully through that posterior capsule tear. Now the connection of this to the anterior segment has been severed. And now you go ahead and do symmetrical, try and do some vitrectomy even around that posterior capsule tear for symmetrical removal. Once you have done that, then we go ahead with phacoemulsification. And believe me, it is safer to do phacoemulsification with the nucleus still remaining after a vitrectomy done rather than without a vitrectomy done. And to do that, I think Dr. Osher's video many years ago was one of the best videos to show why a nucleus drops. And if it's wrapped with vitreous, it's going to drop much, the chances of it dropping are much faster compared to if it is clean and away from the vitreous cavity. So maintain a very low flow rate. We used a flow rate of about 12 cc per minute, and we could manage to remove the vitreous, I mean the nucleus, without a drop in the of the fragment. Cortical removal was done, and now what we are doing is we are doing trying to remove symmetrical vitreous from all around this large posterior capsular tear, to try and make sure that there are no unequal pockets remaining on any other side. So you can notice how easy it is to manipulate or maneuver this probe all around. These strands that you see are dispersive viscoelastic. They usually don't go away as easily, and some will remain, but that's fairly okay. With such a large posterior capsule tear, it's there is no question of an in the bag IOL, and the best way to go ahead to deal with this is to use a multi-piece or a 3-piece IOL. And if the anterior capsule rhexis is intact, the best way to stabilize this lens is to place the haptics in the sulcus, make sure that the leading haptic goes in the sulcus, and then once that is achieved, you just buttonhole the optic through the anterior capsular rhexis, the anterior optic capture. This will do two things. This will make sure that the bulk of the optic is away from the iris, so less chances of uveal irritation, pigment dispersion, and macular edema. And also this will lock the 3-piece IOL in place, therefore less chances of decentration and anything happening. In the end, of course, it's always a good idea to suture such wounds and always reconfirm in the end for presence of any vitreous by injecting triamcinolone, even at the last part or at the end of surgery. There was no further vitreous disturbance in this case, and wound hydration goes without saying. This is the patient about more than 6 months post-op, well-centered 3-piece captured through the anterior capsular rhexis. It goes without saying, a very detailed peripheral retinal evaluation from time to time is required by your vitreoretinal colleague, and keep doing repeated OCTs. These patients are at a higher chance of developing post-operative cystoid macular edema. So the main hesitation that all of us have while dealing with the PCR and doing vitrectomy, particularly with the pars plana approach, is to how do I adapt? It's a mental block that we have. Remember, it's just about 2-3 millimeters away from where you are entering your probe, even otherwise. Interact with your colleagues, interact with your vitreoretinal colleagues, see videos, talk with them, observe how they do. And I think once we get over that mental block, this approach surely helps to improve outcomes in an unforeseen situation like this. So with that, I would like to end my presentation, and thank you so much for the patient listening.
Thank you, Shail, for your wonderful presentation. I think it was you within 4.5 minutes, you could be able to cover most of the take-home messages. I think we have two senior panelists, especially for this particular talk. One is Dr. Nasir Sharaf. I think he has started from, I think, probably intracapsular cataract extraction till phaco. So I want Nasir sir's few message regarding this pars plana vitrectomy, because initially we used to do the posterior lip levitation to get the nucleus into the AC. Some people used to do a phaco. So over to Dr. Nasir Sharaf, sir.
KP, I think we can pass on to Dr. Ramamurthy. I think he's not.
Sir is also here. I think sir has been a tremendous surgeon. I think he's been guiding us for all those years, especially managing such cases. Sir, your opinion.
I think Shail has covered almost everything, and the best I can do is to just summarize some of the points that he touched upon. And basically, the first important thing is to recognize that you are having a PCR. And two things that we fundamentally look for is that when there's loss of followability, suddenly you find that things are all going slow and there's a deepening of the anterior chamber. And that's when you start suspecting that there is something wrong. The most important point that Shail emphasized upon is that at that time you do not pull out your instrument phaco probe suddenly, but go ahead and inject some viscoelastic, preferably dispersive viscoelastic, to tamponade that area and keep the anterior chamber well formed and the tension well maintained so that there's no extension. And just in case, again, he emphasized the importance of using triamcinolone at any point of time. Whenever I have to deal with test strands, I think it's a good idea to use this always. And another important aspect is if the nucleus is really sinking and going down, it's important that you don't go running after that, go chasing after it. But it's best to close up and leave it to your vitreoretinal colleague to deal with it. Of course, often the question comes up whether you can just do a good removal of all the nucleus material as well as do an adequate anterior vitrectomy, and whether you can place an intraocular lens or not. I think if there is enough rhexis support with the kind of fragmentomes and other vitreoretinal equipment that's there, you can always place an intraocular lens, position it properly, and allow your vitreoretinal colleague to deal with it. Then coming to the very important question of whether you would do the vitrectomy through the anterior route or through the pars plana route, I think Shail and his institute, both through their multiple presentations as well as the excellent graphics, have often demonstrated that pars plana is the way to go. I tend to agree, and having done a bit of vitreoretinal surgery, I do not think making incision with the trocar and introducing a vitrectomy probe is very difficult. And especially in a situation like what Shail showed, where there's a large rent, much of nucleus that's left over, maybe going through the posterior route is the right way to go. And there's adequate vitrectomy that you can achieve. But just in case it's right in the end of my surgery, like when I'm dealing with a posterior polar cataract, a little bit of polishing of the posterior capsule, then I have a small rent and a knuckle of vitreous coming out. Let me say that I still prefer the anterior route to do this. And of course, using triamcinolone assisted state to help me. And it's extremely important that you have 3-piece lenses with you, always available to you, because whenever you are in doubt, even though you might still feel there's adequate amount of posterior capsule, you might want to go ahead and implant the lens in the back. Still, I would go ahead and use a 3-piece lens because just in case the lens doesn't appear to be stable, I can bring it out into the sulcus, leave it there, create a good optic capture. If the entire bag is unstable, the same lens can be used even for doing a scleral fixation. So I think unless, of course, it's a very small rent, localized rent, or you have made a posterior capsular rhexis, and you're absolutely sure that you're going to implant the lens in the back. And as far as the IOL power calculation in these cases is concerned, if you're going to create an optic capture, there's no need for varying the power at all. But if you're going to leave it in the sulcus, maybe reduce it by about 0.5 diopters. I think excellent presentation, Shail. I mean, I don't think I really added much to what you presented. The best I could do was to just summarize the points you made out so beautifully.
Thank you, sir.
Thank you, sir. I need Dr. Suhas Haldipurkar, one of the genius phaco surgeon, is also with us. We want his opinion regarding management of PCR, because I have seen him doing live surgery where he even had a PCR and he showed the whole crowd how to manage PCR in his own technique. Over to Dr. Suhas Haldipurkar, sir.
Well, thank you, Krishna Prasad. What Shail has shown is something that one has to adopt today. Like gone are the days when we did, managed vitreous from anteriorly. Pars plana vitrectomy to, suck out the vitreous is probably the best way to go about. And I fully agree with Ramu that, it all depends on at what stage you are in your surgery. Let's say if you have almost done with your nucleus, or maybe a single piece is left, and you have picked up your vitreous pretty early in the, in the PCR, then I would, probably go and manage it after putting triamcinolone. But if it's a larger part of the nucleus that is still in the AC, I think the best option would be to go pars plana. But at the same time, what I would do is, if it's a significantly large quadrant, then I would, after completing my pars plana vitrectomy, I would rather do a scaffolding of a lens which is kept and take that nuclear fragment in front of it and manage it. But it's always important that if you have a larger nuclear fragment and if you still have to do phaco with an unstable posterior capsule, it's better that you have something to support, and the scaffolding of a lens comes very handy.
Thank you, Suhasa. So continuing the spectrum of subluxated lenses, posterior capsular ruptures, we now have tackling subluxation, mild to severe, and none other than the master himself, Dr. Ashwin Agarwal. So Ashwin, all to you, and I would request Dr. Parikshit Gopte to introduce Ashwin.
Dr. Ashwin Agrawal is a smart, dynamic cataract, cornea, and refractive surgeon, and an anterior segment reconstructive surgeon, as he calls it. And he's the executive director and the chief of clinical services and chairman of the clinical board at Dr. Agrawal's group of eye hospitals. Coming from an illustrious family of ophthalmologists, Dr. Ashwin has still managed to hold on his own, and I'm sure we'll be seeing him take ophthalmology to greater heights. Over to you, Dr. Ashwin.
So I would invite the panel for this video, Dr. Suhas Haldipurkar and Dr. Partha Biswas. All to you, Ashwin.
Thank you, Dr. Sonu, and thank you, AIOS Scientific Committee team. This webinar has been absolutely fabulous and stunning in its own regard. So let me continue with my talk today. My talk today talks about subluxations, and I know there are 100 ways to skin a cat. Probably I'm just going to show you guys two favorite techniques of mine, which I think I've been using over the past more than probably 3-4 years now. And I think they're very crucial in different elements. Dr. Chi and what Shell just now showed is actually a prelude to whatever I am going to talk on. So thank you so much, Dr. Chi and Shell, to talk about or put the context in what I'm going to talk today. So I'm going to show you two special techniques of mine. One in a milder case is what I do. If you have a look at this, this is a mild, when I say mild case, the traumatic case, in a traumatic case, more than 180 degrees of subluxation. I've started to move over to this paperclip stabilizer, capsule stabilizer, where I'm making a scleral flap on one side. And I'll come to why I'm making that partial thickness scleral flap later. But the purpose here done is actually make a capsulorhexis. After you're done a CCC and performed your hydrodissection, you can see that this nucleus is rather soft in its own way, but there is some rigidity to it, and I'll tell you why. Well, that's important. After that, I've made a sclerotomy approximately 1.25 millimeters behind the limbus there, and I'm placing this PMMA haptic-based paperclip capsule stabilizer inside the eye. After that, I'm placing now two capsular hooks to hold that bag in place during my phacoemulsification. This paperclip capsule stabilizer goes under the anterior capsular rim at a 2-point fixation. If you see here, there are 2 points here, which is where it fixes, which is why it's also a little bit safer than for a longer period of time, especially because we'll be leaving this and not touching this even post-operatively. Now I'm using a Gabor-Shariat's tunnel at the base of the flap. And now completing my phacoemulsification, as I told you, this is a rather soft one, but nonetheless, soft or hard, no matter what nucleus it is, anytime you remove a nucleus, you will have that bag equator crumpling on itself the minute you remove the nucleus. And that's the important aspect which I want everybody to grab here. So just the paperclip stabilizer is probably not going to be enough. And at this point, I urge everybody, after they are done with their phacoemulsification, to place a capsule tension ring that holds that equator at bay, prevents any vitreous from coming forward, and also prevents any aqueous misdirection, which I think Dr. Chi showed very nicely can happen in these cases, because the aqueous does go behind and hydrate that vitreous, pushing an positive thrust from behind, which is what you want to prevent. Now, after the phaco is done, you actually just remove the capsule hooks and place the intraocular lens in the bag as is. You don't change much. You can actually rotate pretty smoothly because you already have a capsule tension ring. You have your paperclip capsule stabilizer. As you can see over here, it's holding that bag in at bay. And these are the post-operative images of immediate post-op is right here. And I'll show you the first day post-op of it with a 20/20 vision the immediate next day, which is why I'm kind of starting to love this, because I don't have to use any sutures, there's no confusion, and it's immediately over. I don't have to do anything post placing the lens. And this is the post-operative image of day one. This is one case that I wanted to show in a mild scenario what I do. Let's just see another case. And I think this goes on to what Dr. Suhas was talking about just now. If it's a very deeply subluxated lens like this in a traumatic condition, first up, I'm always measuring which way I want to use the glue dial. I know I have to do a glued intraocular lens in this case because it's far too severe a subluxation. But having said that, I also have to remove the nucleus. And in order to remove that nucleus, I'm first making my ports. I've made it at 6 and 9 o'clock. Now I'm using a modified PAL technique popularized by David Chang, and using the modified PAL technique, I'm bringing that nucleus into the anterior chamber using some pilocarpine, and through the ports as well as limbal route, I'm using a anterior vitrectomy. Now, after the anterior vitrectomy is done, because I'm using the nucleus, which is more transparent, and I can tell you I've done even grade 2, almost reaching grade 3 with these in these scenarios. And I can tell you that you can easily see through these blue haptics under the nucleus. So you really have to ensure which nuclei you can see and can't see. Also, you have to see which grade you want to emulsify. I'll tell you why that is important. But the idea here is to basically do the glued intraocular lens under uh, the nucleus. And once this handshake technique is done and you're able to externalize both the haptics outside, and using the Gabor-Chariot tunnel, stabilize this. Some cases, if it's a pediatric case, I even go and put a suture on that to hold it. And just emulsify this. Why this helps is because, as I think Shell also showed, that you want to do phacoemulsification. You want to have some protective mechanisms so that the pieces don't go flying inside the vitreous cavity. The IOL with the small pupil really help you prevent that from happening. Once you're done with this, you can actually also test whether there's any vitreous in the anterior chamber. But fortunately for me, nothing had prolapsed into the anterior chamber here. And what I'm basically doing here is, as I told you, we're done post-operative day 1. These are the 2 cases which I thought was very important. There are far more. There is one more, but I think in interest of time, I'm going to stop with the mild and severe cases, which I thought was very interesting to show in an audience like this.
Thank you so much, Ashwin, for wonderful presentation. As usual, you keep showing some interesting devices to hook the capsule. I think more comments from, I think, Dr. Partha is here. He's been sitting quietly and observing what his committee members are doing. I need his strong opinion regarding, especially you did a phaco, I think is sort of how Amar sir do that, sort of you support with the lens, then you do the phaco. But my one question to you, especially in that case, what Shail showed that, do you have to do a pars plana vitrectomy? We don't know how much the vitreous is disturbed behind. You have put triamcinolone acetate in the anterior chamber, make sure that it is not disturbed. But do you have to really decompress the vitreous or just leave it like that?
Yeah. Thanks, KP, for asking a very, very focused question. I think it's a very important question. And today we really have had a wonderful array of videos shown by so many surgeons addressing similar problems. And now Ashwin has shown excellent videos as well. So about the vitreous in the anterior chamber, and as Professor Chi showed very well, that whenever vitreous is in the anterior chamber, the first thing is to do a vitrectomy to take it out. So with the subluxation and vitreous in the anterior chamber, if the vitreous is taken off the anterior chamber, the actual amount of subluxation becomes evident. So it might be actually a little less or a little more. So once that is done, and thereby the pars plana approach shown by Basoda sir and the group is the right approach to go ahead with. Because even in a case where a pars plana vitrectomy cannot be fully done, and if there is a drop of the nucleus, then the VR surgeon can take over, and the ports are ready to be taken over. So these are a few things that we definitely need to do and think of. The other thing that was shown in Ashwin's video, the paperclip, the Susan Jacob paperclip technique is also very, very interesting and very innovative. And I think once that is popularized, the paperclip can become a very good tool for as an anchoring device.
Suhas sir, your opinion regarding these cases?
Yeah. First of all, I'm happy Ashwin is walking in the footstep his father. Let's talk about his second case. Now, when Amar or he shows such cases, even a decent surgeon gets scared. I mean, these are something like from a fantasy land. So I'll safely go to the first case. Now, first case, he had his traumatic subluxation. One advantage of a traumatic subluxation is that the remaining zonules are healthy ones. So that makes you have already won half a battle there. The only thing that needs to be checked is, like you rightly said, whether there is vitreous in the anterior chamber. And after that, he could relatively get a good and easy rhexis because his other healthy zonules were helping him. And then if you notice one thing, he managed to get that clip, the other end taken out of the bag, taken out of the eye. And after that, he put his clips, put his hooks. Because once you put your hook, the gap between your iris and the lens periphery is obliterated, then it is difficult to get the clip out. And because it's a clip, unless you have rhexis which is firm, the clip cannot be hooked onto the rhexis edge. And after that, I think the case was as normal. And Ashwin, I must compliment you. You have good surgical lens. You really showed both the cases well. And it's been very useful to all the viewers and us also. Thank you.
Thank you, sir. Thank you, sir. So, Dr.
I think Dr. Mahipal, sir, sir, you have to unmute yourself.
Muted, sir.
Yeah, so Sonu, what I'll just wish to say that 2 days ago we conducted a symposium in WOC, and that was exactly on the similar topics, absence of capsular support, etc. And I was also surprised myself. So actually we did an audience poll, and I just taking it out. The 4 questions were, what is your 4 choices were, what is your preferred technique for IOL fixation in the absence of capsular support in aphakia? Professor Chi was also part of that. David Chang was there. Thomas was there. Richard Packard and all. The voting actually surprised me was that 20% of the respondents said that AC IOL is their first choice. 46% of the respondents said iris claw lens was their first choice. 26% said scleral suture fixation was their choice, and only 6% said any form of intrascleral haptic fixation, whether it be the Yamane's technique or whether it be the glued IOL. And that was after 2 talks, one on Yamane and one on the glued IOL. So I'm surprised I was, because normally when we are working in tertiary centers, we do have support of vitreoretina people and we go in for intrascleral fixation. But unfortunately, the people who are they prefer an anterior chamber Kelman multiplex or an iris claw. That consisted of 2/3 of the respondents. That is something that came out. And when we had the first one, that was that if you have a complicated cataract surgery and PCR during that time, at that particular time, intrascleral fixation of the haptics, it was 0%. Not even 1% said that was their preferred thing. So maybe, I don't know globally whether it is something which is preferred or not, but this is the response in the session of WOC held 2 days ago.
I think it is primarily because of the ease of the way you can do the lenses, and I think ACIOL and the iris claw are the easiest to do. That is why they are primarily the first choices. And of course, once if you have intraoperatively, then glued IOL becomes difficult to make the sterile incisions, and people have to still learn it. But I think in India it is a little different because we are, I think, more dexterous as compared to.
Also, I think that the audience probably were from the African region. So probably that's also another cause for that, because they don't have the probably know-how of the glue dial. I'm not sure, but that could be an answer for
So
that.
the audience is, I think, from
want
all over,
to
all
from the
over.
panel or the people here as to what exactly would their first choice be. Is it that we have because it came out of India, so we have lots and lots of talks in these sessions, and has it actually made a difference in the practice patterns of the ophthalmologist? Would they still are people still not, have they totally left Kelman multiplex, or have they totally left the iris clip, etc.? Because Dr. Ramamurthy is here. I think he gives excellent talks about retrofixation of iris clip, etc. So I think maybe if we actually do a poll within India also, whether we are dexterous or not is not the issue, Namrata. The question is, what is the preferred practice in single practitioners, and the number of practitioners who are there in India? Are they still on Kelman and iris clip, or some form of?
We can comment.
We've used multiplex Kelman for so many years, and as such, if you see the Kelman lens, there have not been too many problems with that.
Yeah.
There have really not too many problems, except for the iris claw, which was fixated anteriorly. Again, with the one which is done posteriorly, I don't think there are again too many problems. I think Dr. Ramamurthy has more experience in that.
I think, yeah, I mean, we have been regularly, whenever we are faced with a problem and the capsular support is completely lost, and we are able to do a good and adequate anterior vitrectomy, then we go ahead, and if the anterior segment surgeon is performing the cataracts, I mean, obviously it's anterior segment surgeon performing, and most often it's under topical anesthesia, then slipping an iris clip lens and just creating an adequate enclavation is extremely easy, and it just takes about a few minutes. And at the same time, if you have had a nucleus drop, and if you had an intraocular lens which has got subluxated, and one of our vitreoretinal colleagues is helping us out, and he or she takes over, then what they do is, if there's already a 3-piece lens, or even if they have to replace, they are more comfortable doing a scleral fixation of the lens. So I believe that when it comes to anterior segment surgeon performing a scleral fixation, quite a few aspects that we are doing there, in spite of so many wonderful videos that are shown by all of you, there's certain things which are not visible, which are not, we are not comfortable operating in an area which I'm not seeing. And I believe there have been talks about pseudophacodonesis with the iris clip lens being, but I have not seen a single patient of mine being bothered by it. Of course, as far as placement of lenses in the anterior chamber is concerned, there's enough literature to show that these lenses also do well, but you are always scared of leaving something behind in the anterior chamber because of its proximity to the corneal endothelium. But I think a well-performed iris clip lens where there's enough amount of iris tissue available is an excellent alternative in the right hands.
Maybe Dr. Haripriya and Dr. J.K. Reddy, what happens in your institutions? What is the preferred modality for if you have a PCR large enough to not support a sulcus lens, or there is the dialysis or whatever? Is intrascleral fixation the preferred choice, or people people go in for Kelman multiplex or iris clip retrofixation?
In our institution, we do iris clip lens for a long time. In fact, when we had first the problem of the lenses available, because only Daljit, as you know, Professor Daljit Singh has developed that, and there's very small lenses. Then we collaborated with Excel Optics in Chennai and made a quite sizable lens, big size lens with a plano side on both sides. In fact, we developed that lens in our institute, and we are exclusively using the past 15 years. That is our first choice, as Dr. DR has explained rightly. When you're doing in topical anesthesia, it's quite simple to just clip the lens, extend the incision to 5.5, and clip the lens and put one suture and send the patient. And even in our charity side also, that is our preferred technique. We use on average around in a year, somewhere around 40,000 cases we do on charity side. We use around almost around 600 to 700 lenses per year. The complication is quite very low when compared with anti-chamber lenses, or the time required for scleral fixation.
Dr. Haripriya?
Yeah, so we are not doing many anterior chamber lenses. The reason being, I think an anterior chamber lens is very easy to place, and a well-placed lens does very well. But considering the spectrum of surgeons we have, we found that when we have that option to the surgeon, some surgeons in training tend to use them without the right sizing, not taking care of the witches properly, etc. So we had issues post-operatively with glaucoma, endothelial damage, etc. So we've decided to stay away from anterior chamber lens for this reason. But someone who's really senior, of course, they would probably still choose an anterior chamber lens if they want to. In terms of the other options, the different surgeons choose different things. Most of the VR surgeons, if they would like mention, if they had to do a combined surgery of a vitrectomy and IOL placement, they would do a scleral fixation, Gebauer-Chariot's technique. The anterior segment surgeons, many of them do either the iris sutured or the iris claw lens. So this is what they would do. Few of them still do the scleral tuck technique, even the anterior segment surgeon, but very few of them. And some would still do the scleral suture. So it's a kind of a wide range of techniques, considering we have different centers and different surgeons based on how they are trained, they would choose them. So there's no one specific technique. But I think the training also matters. The VR surgeon most of them would do this, while the rest would probably do a more limbal approach.
So you guys are pretty good at demographics. So supposing you were to do a poll or you were to look at your percentage of cases which have had Kelman multiplex / an iris clip / scleral fixation / an intrascleral, maybe you could go back and check, and it'll be a good learning for us also as to what is the preferred practice, because you have big numbers, and what are the outcomes.
I think the only difficulty in that is that the cases are so varied. Whether it's a primary surgery, secondary, is it traumatic, or is it a complication, is it combined? So the other variables as well, which could affect the outcome. So that's
as far as the Kelman multiplex is concerned, one major consideration is the sizing of the lens. You get good results if the sizing of the lens is appropriate. And the difficulty is when you have a complication on the table, measuring the white to white and having the right size lens available is often a challenge. So whatever published literature is available, it's more based upon extremely well-sized lenses placed by very good experienced surgeons. But as was mentioned, when complications happen more often in inexperienced hands, and when you allow this to be these lenses to be placed in traumatized iris, maybe some amount of witches there, then it's a disaster for the asking. So in these cases, I think, of course, even for iris clip lens, you have to do a good anterior vitrectomy, then only do the intervention.
I think we could do a survey on the practice patterns of intraocular lenses. It will be a good idea to do it. I think there's already one which is prepared, so we can maybe just float it around.
So what we did is I collected data from manufacturers, how many lenses they bring per year, so that we know the trend roughly, what is the lens of preference. The Kelman is dropping down, very, very few lenses. Only Aurolab and few companies are making. And iris class suddenly is increasing. Now more and more companies started making. Even South India, 3 companies are making. So the volumes are going up, almost 600 to 800 lenses per month they are selling each company. So that comes around 2,400 lenses. Whereas Kelman is selling only around 20 to 30 lenses per month. That also now disappeared. You have to pre-order, buy, and keep it yourself.
So, looking to the paucity of time, I'll request to end the discussion here. And thank you, Ashwin, for that wonderful talk and bringing out those wonderful points. Thank you, Mahipal, sir, for highlighting. I think it's the hesitation to do the vitrectomy in most of the anterior segment surgeons. I think that is one of the limiting factors for a single chair practitioners that we've observed. So let's move on to the end of this webinar. And it's something which is interesting, the grand debate. And we have world's 2 finest innovators and surgeons themselves talking about ways to manage the small pupil. So let's hear from these master craftsmen and let them have rolling. So I would like to invite Sergio Canabrava and Subin Bhattacharjee for this wonderful debate. We have on panel our president, Dr. Mahipal, Dr. Partha, the chairman scientific committee, Dr. Ramamurthy, then Dr. S.P.S. Grewal, and Dr. Haripriya. So I'll introduce Sergio He is the member of the Brazilian Society of Cataract and Refractive Surgeons. He is the cataract preceptor of the Santa Casa di Belo Horizonte. He is the creator of the double flenched and the four flenched technique. And he'll be talking on his innovation, the Cana Brava ring, mastering in small pupil. So all to you, the master batsman, Sergio.
Hello, hello.
We can hear you, Sergio. You can start sharing the slides.
Thank you for the invitations, Dr. Sono, Dr. Partas. Thank you. For me, it's an honor to be here. I'm without video here because I'm outside of my city. I'm in my farmhouse, and here the internet's not so good. Can you listen me well?
Loud and clear.
Yes, very well.
Okay, thank you again. It's such honor to be here. And today I will discuss about Cana Brava ring, mastering in small pupil. Here my disclosure about this talk. And here is the ring. For the first time, a ring with PMMA was produced without sulcus. If you can see in the image, the ring, there is no sulcus. There is one indent above, one indent behind, and the second one in the market in height, because the number one is the BX pair with ring, Oasis, Morsche, and Meliungi. The Cana Brava ring, there is
Sergio, you'll have to check your net. There is
0.4 millimeters in high. My sorry,
the voice is breaking.
Sono, can you? It's not good. Are you disconnect and try again and Suven?
The voice is cracking. You want me to take Suven first?
If you can go Suven first, I will try again to reconnect.
No problem.
No, I think let him go on. Let him go on his week, so it will keep coming.
No, I think we can just switch on to Suven. Sonu?
Yeah, Sunil, can you play the video of Suven? Suven, can we start?
Okay, just a minute. Yeah, so yes, a bad internet connection. So what I've done is I've
just introduced
a presentation into a video, and can you hear me? Hello?
Yeah, we can hear you, Suven.
Can you hear me? Can you hear me?
Yes.
Yeah, loud and clear. We have your video.
Small
So
there's a small introduction about sector of Nayan Eye Care Private Limited, and he is inventor of, as we all know, that Blue Hex Pupil Expander. There is none other than Bhattacharya ring with, I think most of them has accepted his ring. So I'll much wasting his time. I think over to Suven.
Thank you very much, Kudlu, for the kind introduction. So I have got a weak internet too. So looks it's the same fate with both the debaters. So I've sent my video, my presentation as a video to the webmaster. So can I ask you to play the video, please?
Play the video.
Sunilji, can you please play my video? Upon the scene. Can you start from the beginning? I'm Suven Bhattacharya, and I'm talking about the choice of pupil expander in small pupil in general and IFIS in particular. Thanks to Dr. Deepak and Dr. Neto for the videos. So the first message is elastic pupil stretches like a rubber band, any device would work. Rigid pupil does not stretch, needs to be torn, needs a bulky pupil expander. Message number 2. In IFIS, for the meiosis component, it's elastic pupil. So iris hooks or pupil expanders both would work because they provide a constant pupil size for good visibility and safe phacoemulsification. Whereas for iris prolapse, no device helps because it depends upon the severity of the IFIS. So when you don't have iris prolapse, it just means that it is a low-grade IFIS. Chang and Campbell in 2005 distinguished the IFIS pupil from the rigid pupil that it snaps back immediately after it's stretched. So here we have an elastic pupil, so even a thin device like the B-Hex can stretch it. As alternate flanges are tucked under the pupil margin, we have a nice 5.5 millimeter expanded pupil, which is good enough for phacoemulsification and IOL implantation, and removal of the device is extremely easy as you untuck and draw it out of the incision. On the other hand, this rigid pupil needs to be stretched with either two Kuglen hooks or with the pupil expander. Here we stretched it with two Kuglen hooks, so we can go ahead and use the BX pupil expander, and once we have stretched it, it's so easy for any device to expand the pupil. And as we can see, a 5.5 millimeter pupil is adequate for even the hardest cataract. And removal of the BX is indeed the child's play. So, the choice of the pupil expander depends upon how you wish to tear the rigid pupil. With two Kuglen hooks, you could use any device, including the hair-thin BX, which allows you a lot of space. For the pupil expander to do the job, it has to be bulky. Let me show you a case of severe IFIS where iris hooks cannot prevent iris prolapse. Even before I have finished my capsulorhexis, the iris looks like a fishing net and is completely frayed. So hooks or pupil expanders do not guarantee against iris prolapse. They do ensure adequate pupil size for safe phacoemulsification. We see the knuckle of iris prolapse from the side port, and the iris moves like a sail, and it's so patulous as viscoelastic is injected. The iris needs to be protected as the IOL is injected, and you look at that iris. So, iris hooks did not prevent iris prolapse, it only gave me good visibility. And this is a case where we have a short eye and it's posted for toric IOL. Now, the BHEX cannot prevent iris prolapse, but it does provide me a constant 5.5 millimeter pupil for safe phacoemulsification because I have good visibility throughout. The iris is prolapsing through the side port and to the main incision, but I can implant the IOL and align it to the axis. Since the BHEX can be removed through the side port, it is invaluable in this situation. And we have a nice round pupil in the end. This is intraoperative meiosis, where the pupil comes down as we start the phaco. So a little viscoelastic is injected under the pupil margin to lift it off from the iris, and the thin BHEX is tucked under the pupil margin. As the flange is tucked under the pupil margin and advanced to the periphery, there is instant confirmation that the capsulorhexis margin is not engaged. And now we are back to our comfort zone. And the surgery becomes so much safer. So, in IFIS, the pupil expander should require a small incision, should be very thin, and should be able to exit through the side port. So, if you want a simple device which allows a lot of space in the anterior chamber, it's the BHEX. Whereas, if you're looking for a device to tear the fibrotic pupil, it would be the Malugin or the APX, but then you could do that with two Kuglen hooks easily. Please look up eophtha.com for the 10 tips for phacoemulsification in small pupil. Thank you. Thank you, Sunilji. Thank you very much. And thank you, AIOS, for this opportunity. So if we can have Sergio back.
That was really a wonderful presentation. Yes.
Yes, can I try?
Yes, sure.
Yeah.
Let me see. Let me see again. I think now my internet, I did the speed test. I think the internet now is better. Let me see.
I put in a good word for you, Sergio.
Now it's better?
It's fuzzy. Yeah.
Okay, I will restart in this point. Then this is the first ring produced in PMMA without sulcus. Okay, you have idents and one ident above and one ident behind. And then because this, you have only 4.4 millimeters in height. The second one in the market, the number one in this point is the BX for my friend Suvan, but in compare with iRing, Oasis, Morsher, Malugin, you have 0.7 to 0.9 millimeters. Here you can see how the ring engage in the iris like a wave. There is no sulcus in this ring. The sound now is good. My sound?
Yes, yes.
Oh, perfect. Okay, I like to call my ring to challenge ring because the learning curve to this ring is not easy. It's challenge to start this learning curve. But when you have the learning curve finished, you can do a lot of challenge case as I can show you. Here patient with so teeny small pupil, and you can see this patient is a small, a very shallow anterior chamber. Then you can connect first the small one and use light to stretching the iris, and then you connect the second and the third small one, and finally you connect the hooks to give the stability. Here another case that you can see connect is the same way, the small indent behind in the center, and the second and the one in the third one, and you can see how the bigger one goes goes above the iris to give stability, and the final two hooks give the final stability. In this patient, I perform Yaman technique, but why, Sergio, you don't did the Canabrava technique, your technique in this kind of patient? Because in patient with small people, I suggest to use Yaman technique because you can insert the IOL inside the eye. Then I have some tips, some hints here. I like to do one flange in one side first. And again, I use a microforceps to hold the haptic, and then I remove the insulin needle. Then you can see, and now I will remove the bag, and then I remove the ring from the eye. I use a simple microforceps forceps. I disengage it on the iris and remove a simple microforceps forceps. Then a patient, a flex, because this ring, you connect the same way. And then I go with the patient. In my hospital, I have a Johnson & Johnson Catalyst, and you can see the ring stays stable inside the eye because it has 0.4 millimeter high. Then this is you can introduce it in the 0.4 millimeter incision. Then I back to the operating room, and I like to insert first a capsule tension ring. And after to insert, I like it because when I insert the capsule tension ring before, you can stabilize it, your bag. And after to do the fake emulsification, insert a 3-piece IOL, I remove the ring from the eye using a simple microforceps forceps. And then I finish the surgery. Fixate the iris using a simple knot, as you can see. And then it is finished. Then here, another catalyst report, Johnson & Johnson, to see another patient that you can see how the ring stays stable in the anterior chamber during the fake emulsification. And here is the ring. Today it's available in all South America, and the Europe CA mark is coming to go around the road. Then thank you again for the invitation. For me, is an honor all time to invite me to talk to India. Thank you.
Excellent presentation, Sergio. I think now the real debate starts. I think we have all senior panelists who will give their own opinion. I think we will be very much transparent as far as the opinion is concerned. Dr. Partha is smiling. His choice will be different. And even I think Dr. Maipal is also around. I think to start with Dr. Partha, what is your opinion? If you given a chance, similar condition, do you will use Sergio's ring, or you'll go back to your close friend who is your neighbor, Dr. Suven?
Well, thank you very much, KP, for throwing the ball in my court. Well, since I've used Suven's ring and the BX ring for quite a long time now, I'm very comfortable with that ring. And obviously, as lazy people, we keep on the comfort seat as much as possible. However, I just have a few questions for Sergio. Sergio, are you there? Are you listening?
Yes, I'm here.
Okay. So what I thought is the ring is a little bulky, Sergio, and you had a little, the manipulation on the iris is a little there, and the rotation of the ring. And my question would be that how much of iris depigmentation would normally occur when anybody is placing the ring to widen the pupil? And removal as well. So removal, during the removal, what I saw is you were twirling the ring outside, and that would also, I believe, would it take off the iris pigments and cause a little bit of maybe iris inflammation? Means I want your opinion there.
Martha, is an important point because this in all my presentation I tell this is a challenge ring. For example, BX is easier to implant. Malugin ring is easier, the learning curve, but the Canberra rings is really hard the learning curve. Then you need to do a wet lab to avoid these things, this concern you told me. But after you complete your learning curve, what I can say is no ring do challenge case like my ring, because it is in a PMMA. You can use it in the fibrosis case, and it has a 0.4 millimeter high. Then it's an advantage is a PMMA and alternate parts. But it's a challenge case. You need to avoid all the things you said.
Okay. So let's go over to the next panelist.
Yeah, Dr. Mahipal, sir.
KP, the issue here is actually experience. So as the Canberra ring is not easily available in India, I have no personal experience on it. But I think whatever Partha said, it is a matter of being happy and what is in your comfort zone. If you're getting good results with any particular thing, at times you don't wish to change. Now, obviously, the two things what our friend Suvain and what Sergio are trying to do is that Suvain is trying to make the size. So the comparison is actually always with Malugin. So from a Malugin, Suvain tried to make it less bulky so that he can push it through even a side port. And the only thing is that obviously because it is less bulky and less strong, so it needs some manipulation to kind of stretch the iris and then put the ring. So that is what Suvain has really done, and it has its advantages. And what Sergio has actually done is to make the ring more bulky and to be making it more stable. Obviously, I feel because it's going to, even in a fibrosis case, what Suvain showed was that he could use two Ys of a manipulator and do a stretch and then put the ring. There'll be sphincteric tear with that also. And I think what Sergio has shown, I have no personal experience, but I think that will also have a little bit of a sphincteric tear. It would require more difficulty and more skill set. That's what I feel to put in the Canberra ring. So as they say in FACO, there are 100 ways to skin a cat. I think there are several rings that are available. The iris retractors work pretty well in majority of the cases. Malugin ring works very well. Suvain's ring works very well. So I think there are advantages and disadvantages. I wouldn't wish to take any sides because I don't have personal first-hand experience with Sergio's ring. So it's improper for me to comment on something that I have not worked on.
Thank you, sir. But we have with us Dr. Haripriya, and I think she's part of Arvind's system. They've been, she's been doing their manufacturing so many rings even in the Arvind system. So I just wanted to ask her to given a chance, which kind of ring you prefer to manufacture at your system?
I don't know.
Dr. Haripriya? Yeah, she is not around.
I think.
Yeah, Dr. Ramurthy, sir, your opinion regarding these two rings?
I'm always called when somebody is not available.
No, sir.
So why are you so available, Ram?
Okay. So, I mean, I think that was a beautiful video from Suvain. And there's a very important point that he made about, rigid pupil and elastic pupils. So I find quite often you can get away without using any of these devices. The first thing I would do when faced with a 3 millimeter, 2.5 millimeter pupil is to go ahead and fill in some cohesive viscoelastic and make the eyeball really tense. very often you find that you get a 4 or a 4.5 millimeter pupil expansion just with this, and maybe you can use some intracameral Mediatic also. That itself would suffice, and you can go, especially if it's not a very hard cataract, you can go ahead and complete your phacoemulsification. And sometimes if there is a membrane over there, if you just peel it off and do these devices, then maybe a device is not required. Then secondly, when it becomes a device, becomes a requirement, one thing I've seen both with the Maligan ring as well as Suvain's ring is that in extremely small rigid pupils, it's quite difficult to introduce. And some amount of stretching that becomes necessary to enlarge it to about 3.5 millimeter before you can introduce these rings. And but especially in a case of IFIS, I would keep away from completely damaging the sphincter in any way. In these cases, I find that using an iris hook is helpful, because even if it's a pin 2.5, 2 millimeter rigid pupil, I'm able to use the iris hooks and get enough amount of expansion. And of course, Suvain's ring, I've used it. It's a great product. I think I find it more comfortable than a Maligan ring, simply because it goes through a much smaller incision, and removal as well as introduction is extremely easy. And maybe a 3.5 millimeter pupil, I go ahead and use that. Often it's, for me, is a toss-up between iris hooks and Suvain's ring. And Sergio's ring was very impressive. I have no personal experience with that. And obviously the fact that he could do it in a 2 millimeter pupil, and he could even do a elastious docking, is something which is impressive. Maybe look forward to use it. But I think Atmanirbhar is the tone today. And if you have to opt for something, Suvain Jindabad.
Thank you.
Dr. Grewal, sir, your opinion? He's around, Dr. Grewal?
Yeah, I'm here. You see, one thing I like about both the rings is that both the rings dilate the pupil. So that's something really what both the rings are delivering, what both the rings claim to be. And it's purely a matter of the training. It's a matter of which product you are trained into it. And as Sergio rightly said, that maybe his ring needs a longer learning curve. And once you are used to that, then you can handle that. My personal experience, I haven't used either of them so far. I'll be able to mostly manage the cases even without using a ring, or if used, I am still old set and using the iris hooks. Thank you.
Dr. Devashish, sir, your comments?
Yeah, the Sergio's ring looked very impressive, but I would go with the panel and say that, you know, everything works well, and whichever is available and is cheap. But I would beg to differ with Ram and SPS on this issue, that when it is IFIS, you know, we need to put a ring. Because in the later part, it generally starts misbehaving, and then it becomes very difficult to put the ring, because then you can injure the rexus and do so many things. So
I think you got me wrong, the sense that, you know, in case it is IFIS, it's definitely some kind of a dilating device is required. What I don't want to do is to even stretch the pupil to even introduce that device. So in these cases, though Suvain showed some difficulty with the iris hooks in place, I normally use 5 hooks and 1 sub-incisionally. This gives me a reasonably good dilatation for the surgery to be performed adequately. So I would not really do any stretching in these cases, but definitely if it's an IFIS case and it's a rigid pupil, go ahead and use a device.
Yeah, I understand, Ram. But I'm of the opinion that I would expand the pupil so that I see well. Of course, the hooks do the job well, but sometimes, you know, the iris is so floppy that it keeps coming, even with the hooks on, it keeps coming in the main wound and that kind of thing. So essentially, I'm quite comfortable with expanders, and I think this is, I don't have no first-hand experience with the Sergio's ring, but it looks impressive. It just is a thing that, I mean, what price and the availability. So, yeah.
Suven, the video that you showed actually when you are showing iris prolapse from the main wound, actually if you put another hook there, that solves the problem.
Yeah.
So actually that is the thing that normally is being done if you do iris hooks.
Yeah.
So J.K. Reddy, sir, any comments from you?
Sir?
Dr. J.K. Reddy? Unmute. Dr. J.K. Reddy?
Dr. JK?
You're muted. Dr. Reddy, you're muted.
I generally, I agree with what Dr. DR said. When the pupil is very small, where we cannot perform, these rings are also becoming a little difficult. I tried. It's not question of I am not tried. I tried the rings. This is becoming very difficult, either Maligan or Swin also. Sometimes we have to expand. Whereas the iris hooks goes when the really small people like 2 millimeter. 4, 5 millimeters, usually we are able to manage after some experience without any expanders, unless it really gives trouble. So the use of rings are becoming slowly, it is coming down in practice compared with our initial enthusiasm. Now we are going back to iris hooks or no ring. We learn how to do without rings in a moderate people, small people.
Yeah, Shuven, you want to say something?
So what I want to say is, again, I would like to emphasize that the IFS pupil is typically elastic. So you can use anything. That's something you must understand. Whether it's 2 millimeter or 1 millimeter or 4 millimeter really doesn't matter. If it's a typically IFS pupil, it is elastic. That is the nature of the pupil. Now, if it's a 3 millimeter and fibrotic pupil, then you'll have to stretch it anyway, whether you stretch it with the hooks or with the Malugan ring or with the Sergio's ring or the B-hex, it doesn't matter. So it's if it's like a rubber band, it will stretch. It will expand. But if it's like a string, there's no scope for it. You have to tear the sphincter. How to tear the sphincter is up to you. So if it's a typical IFIS, it is in elastic people, the size really doesn't.
So Partha, I think if we can, to finish off the debate, let us ask both these guys who have commercial interest as to how many rings are sold per month in the world. Suven, how many rings do you sell per month?
So that's like asking
it's
how many
a secret. It's a secret.
Yes.
So that will show the popularity, no? How many rings you are selling per month?
We'll come with the figures. We'll come with the figures very soon.
Both are manufacturers.
It's a secret.
That's a trade secret, I believe.
Not really. Not really.
Dr. Reddy gave the figures on the iris clip lens manufacturers thing. So why can't Suven and this thing? You must be your tax return.
There's nothing very confidential about that. It's just about the availability. Yes, in India, definitely we are leading, and I know that. But
Reddy doesn't manufacture iris clip lenses.
Because there was no sales at Malugan ring usage.
I think that.
I think everybody's waiting for your presidential dinner, sir.
I think
a word from Sergio. I think let's have a word from Sergio. Sergio, are you there?
Yes, I'm here.
Yeah.
So how many rings do you sell?
Would you like to use Suven's ring? Sergio, would you like to use Suven's ring?
Yes, for me it's a pleasure. How I told you before, in serving ring, eye ring, Malugi ring is amazing rings to start your learning curve in iris expansion ring. And it's an amazing ring to do in a simple small case, small pupil case. I suggest all my fellows and residents, if you want to start in a small pupil with iris expansion ring, first try Malugi, try a ring, try serving, because it's easier than my ring. But after, if you need to do a really challenge case, I tell my ring is better for challenge case. I have more than 200. I experienced more than 200 patients with all rings you believe you know. I ring, and it's my concern for learning curve.
Okay. Now, Suven, would you like to use the Canabrava ring when you're challenged?
I forget an opportunity. I would, and of course, like Dr. Devash said, that it's stiffer, so that has its own merits, and even a thinner lens has its own merits. So there will be a situation-based use.
Thank you. I think we've had both the last comments, and the debate has been a great one. I think Sir Maipal sir and all panelists, I'm sure, would agree that we have the best in the world. We have the best in the world. So I think over to Sonu and Kudlu and Maipal sir.
I think if I
word from Dr. Maipal sir.
Can I make a comment on the Dr. Mahipal's question to Dr. Suvain, if I can answer on his behalf? I think it's just like asking a lady what is her age. So that is the reason both Suvain and Sergio were a bit hesitant in answering that number, what they're selling. Over to you, sir.
I don't think they need to be apologetic about it. Actually, I'll be proud if I have a product and my baby is doing well. I would give the numbers as long as Suvain has some tax evasion things to do. Otherwise, I'll be happy to say that I'm selling 1,000 rings a month or 2,000 rings a month. So that shows the popularity. I don't know, Sergio, why are you hesitant in saying as to how many are sold? Because the proof lies in the pudding that basically how many people are doing those things. He diplomatically, Suvain said that's the largest selling thing in India. So
I can tell you the figures. We are selling about 800 rings a month pre-COVID, and post-COVID we are a little stuck now. And the problem is we have a lot of demand overseas, but because we are not FDA registered or CE marked, we have our own reasons. So in fact, is nodding. She is one person who wants to use it, but I just can't send it over. There are a lot of people who use it unofficially. So that is a constraint that we have. But once we have that, I think we'll roll out much more now, many more.
Great. So you want any help from us, we'll be there to help you.
We all need all the help.
Okay. Good. I need some shares of your company, right?
I need you as an advisor.
Okay. Advisors also get ESOPs, right? I think it was a great session. Sergio, maybe do you wish to comment as to how many of these you sell?
In this moment, I was selling only in South America, but I really can't share it because it's a company. How can I say?
Okay, fine. Anyway, I think
it's a secret. I really can't share it. But today you are sell only in Brazil and some countries in South America. And
so maybe give us some samples and we'll use, and then we can talk about your rings also.
For me, it's a pleasure. Who wants to receive a sample? Send me an email. I will send the email for the company.
I think all of us want samples, sir.
I'm not sure, but I think JL from Spain would like to send some samples because it's important to talk about the ring.
Okay. Anyway, thank you very much. I think the scientific committee as always has done a great job, and Sonu, Kudlu and Partha, keep up the good work. I think always having interesting webinars, and great to be part of them always. Back to you, Partha.
Thank you very much, sir. And thanks to everyone, all our presenters who have presented mind-boggling videos, to our panelists, and to our overseas experts. Professor Chi, I think it's so late in the night and you still are there. I'm so happy, and thank you so much for being till the last. And Sergio, also thank you so much for taking time at your farmhouse and getting connected to India from your farmhouse. And we'll love to have you in our webinars again and again. And thanks to all our panelists who have been the experts and given your opinions. Thank you very much. Kudlu and Sonu have worked so hard to bring this together. Yes, to bring this together. All credit to them, all credit to them. So a last word of thanks from Kudlu and Sonu, please.
Thank you, sir.
Yeah, Kudlu, please.
Thank you, sir. It was like First of all, since you had thanked everybody, the man behind this show, none other than Sonu, who has taken so much of work. In the end, only I was with him, but he has communicated with all the panelists and all the chairperson. The program was excellent. First of all, I have to really thank our President AIOS Maipal sir, he with us from beginning till end, Dr. Namrata Sharma, and our chairman scientific Partha Bishwas, and all our scientific committee member, Dr. Parikshit, Dr. Amit, Dr. Balla, Dr. Fairoza, Dr. Somshila Murthy, everybody was chipped in between whenever we wanted. And also I thank all the presenters, especially the international speaker like Sri Fashionov, Professor Chinsu Phai, and also the Kanabrawa. He has also chipped in with the very nice presentation. All our Indian faculties, even senior surgeons like Dr. Titiyal sir, Suhas Haldipurkar sir, Grewal sir, everybody chipped in. Once again, from the bottom of my heart, I thank everybody who helped Ramurthy sir, even Haripriya madam, Rajesh Sinha, who really chipped in with the very good presentation. Even in spite of we have been with the doing a lot of cataract surgery, every time we keep learning so many things out of our cataract webinars. Once again, I think we'll be coming back with under Partha's guidance in coming soon with some more edition of cataract and refractive sessions with the permission from AIOS headquarters. Thank you, one and all.
I think I'll just like to mention special thanks to Professor G for, we are really very sorry for keeping you so late in the night. And thank you so much for every time accepting our invite. Sergio, thank you so much. You're a dear friend and you've been always been with us. I think AIOS is all about leadership, and it starts from the top. Our president, the dynamic president, who on a single call would answer in a minute. I think that is a wonderful quality. I should really appreciate Dr. Mahipal sir. A single phone call or a mail or a WhatsApp within a minute is answered. I think thank you so very much, sir. Namrata madam, she would never say no to anything. And our chairman scientific committee, Partha, who has so much confidence in the scientific team that he would leave everything on us. I think these are the qualities which make a society, move forward. And yes, scientifically, as Steve said, that we are one of the most learned community in the world. And challenges, innovations, and the video kind of stuff, I think India's are far ahead. And looking to what Suven presented and Sergio presented, I think, yes, Indian ophthalmology is, is bound to grow leaps and leaps. Thank you, Dr. Devasi sir, Suven, Grewal sir, Dr. Tiyal sir, J.K. Reddy, Amit, Parikshit, Somashila, Haripriya ma'am, Maipal sir, Feroz, Dr. Ramamurthy. I think they are here, Dr. Bhalla. And last but not the least, let's keep things rolling. And the basic aim of this meeting was to deliver some pearls to all our fellow members who are struggling or are in the process of learning. So I think goals well achieved. Thank you so much.
Thank you, and good night to everybody. Have a very, very safe year ahead. And till the next webinar, we are back